The webinar's live.
Thank you very much, Noreen, and welcome to the September governing body for NHS Cheshire CCG. My name is Dr. Andrew Wilson. I'm the chair of the CCG. Clearly, this is a virtual meeting held virtually because of the COVID-19 restrictions. Members of the governing body will introduce themselves as they first speak throughout the course of the meeting. We speak virtually because of COVID-19, and we speak at a time when, of course, COVID-19 infections are rising throughout the country and rising in the northwest, unfortunately, at a slightly higher rate than they are in other parts of the country. We're also, unfortunately, starting to see some people needing hospital treatment with COVID-19. So I did want to make a plea before we start the business of our meeting about people taking COVID-19 seriously and complying with the advice from government in terms of social distancing and use of face masks and hand washing. I think it's really important that we all do play our part, try to reduce the increase in infections that's happening in our locality and across the country. We were due to be joined by our Director of Public Health. One just had to give his apologies, but the other is hoping to join us later in the meeting. And it is our Directors of Public Health who are leading the local responses for much of the COVID-19 work. I also wanted to say a thank you to the staff who are working throughout health and social care. I have been doing, of course, throughout the pandemic. And whilst there's been less COVID-19 infections in the last couple of months, of course, people have been working extraordinarily hard to restore services and to get the NHS and care services back to as much as normal as they can be with the restrictions that are still in place because of COVID-19. And in particular, I wanted to, of course, as a membership organisation, mention our member practices who have been working and have been providing a service throughout the pandemic. And I think many people are aware of some recent media attention which suggested that some practices haven't been open. And I can assure people that practices have been open and have been seeing patients and continue to do so. So we do want you to use the NHS when it's necessary, so please do so, but use it in a sensible way. And so I just want to again thank the staff. I know that many are tired emotionally and physically from both dealing with COVID-19 and from dealing with the recovery. So I think we do owe gratitude to people who have been working hard throughout that time. So that's just a bit of background and setting. If we can move now into our main meeting. I believe we have apologies from Matt Tyra, and we know that Ian Ashworth is going to join us late if he's able to join us at all. Mandy, are there any other apologies for the meeting?
They're also from Neil Evans, Executive Director of Planning and Delivery.
Thank you very much. That then moves us just to confirm that actually the governing body is quorate today, and then to declarations of interest. Everybody does have a declaration of interest which is published on our website, but I will pause now for any member of the governing body to point out if there is any item in particular for which they feel they're conflicted on today's agenda. I will, before we do that, mention that item 5.1, of course, is about the remuneration of GP members of the governing body, and therefore those members are clearly conflicted. I think the way that we'll deal with that ordinarily, because that is a monetary conflict, we would ask you to leave the table if this were an ordinary public meeting and then go and sit in the public gallery. I think the virtual way of doing that will be for you to simply mute yourselves throughout that item. I think that will suffice. So I will pause now for anybody to point out any conflicts of interest which they feel pertinent to the rest of the agenda. No, thank you very much. That takes us then to the minutes, which start on page 3 of your pack. So page 3. So actually, before we do that, Mandy, are there any alterations to the minutes that we've received in advance?
No.
So page 3, page 4, page 5, page 6, page 7, page 8. Got to catch up now to make sure how many pages there are. Page 9, page 10, page 11, page 12, page 13.
Dr. Wilson, could I mention something?
Yeah, please do.
Wording's entirely correct, but I think there's perhaps been some spacing issues as they've perhaps been PDF, so that I just wouldn't want the wording to be misconstrued, as we've got a B ACLOG and a L ARG, so that just might need to be amended to make sure they're entirely accurate.
Whereabouts are you looking, please?
Page 13 under 6.1, if you go down to the bottom to last bullet point, sorry, the third bullet point from the bottom, there will be a backlog of work in a large number of NHS services, and some of the spacing I think may have gone amiss. Does that make sense?
Yeah. I think,
Thank you.
Yeah. As you said, that probably is a PDF-ing thing, isn't it? So thank you. So that was page 13, page 14, page 15, page 16, page 17, page 18, and that is the end of the minutes. So I think we're accepting those as a true reflection of our meeting. Thank you very much. That takes us to the actions. Fortunately, most of the actions are completed. So I'm just trying to find the action log. So the there is one which is ongoing, which is the Health Watch survey, which remains open. So that I think that's right, that stays open. And we've got one which is I think a request from the governing body last time about the Public Health England report, and that was a Public Health England report on inequalities around COVID-19. So my suggestion about that is that later in the agenda, very shortly in the agenda, we're going to be appointing a governing body champion lead for inequalities, and I suggest that we perhaps we reconfigure that with that lead, which is going to be Claire, with your agreement, and that we perhaps bring that back, leave it on the agenda, sorry, on the action log, and I'll discuss with Claire about how we perhaps take that forward and fulfil that. If that's acceptable to everybody. Yeah, thank you. So with the agreement, I'll move on, accepting everybody agrees that the other actions have been completed. That moves us forward into the patient story. So Noreen, are we confident about the IT?
Hopeful.
Hello, my name's Anthony Spurway, and I'm going to read about my story. At 6 months old, I was not very well and had to go into hospital. After this, I have always been in and out of hospital throughout my life, with problems with my heart, ears, and my eyes. I was in mainstream school for both infant and junior school until I got statemented. As I started senior school, my statement said I had global difficulties which means level of understanding of my life skills. I didn't have the option to gain any qualifications while I was at special needs school. So how do I get into the world of work or go to the local college if I don't have any GCSEs? In the end, I did get into the college and gained a few qualifications. When I eventually left college, I tried to get a job. For the interviews that I went for, I had to do tests for, which let me down very badly. When I eventually did get a job, I did in-house training, which led up to a qualification. I needed help with other staff that worked with me. Having a low-paid job and living on my own, I got into debt. I found myself sleeping in my car between shifts and waiting for the next pay packet to get food in. I found myself homeless. With my mental health reached rock bottom. Then I was in a halfway house. I was asked for help for all these organisations: Department Work and Pensions, Citizens Advice, Shelter, Health Professionals, the Council and housing providers. I found this very hard going because I had to explain my situation over and over again, which is hard going to find a solution. I went for counselling to have an understanding of my mental health and situations that led up to this point, which had a positive impact to me to move my life forward. In the end, I did get the help that I needed from Cheshire West Council, and other partners came to my rescue, and my benefits came through. It takes years getting over this experience, and truly it's always in the back of your mind. I will always need the extra help for my future in supporting me in my life for health, education, employment, applying for benefits, having a healthy bank account and a nice home. I will need all these agencies to keep me in a positive impact to my life. Thank you.
Thank you very much, and a very powerful story from Anthony. And the reason that we felt that fitted in was to fit in with our strategic objectives later in the meeting. I think the strategic objectives speak a lot towards wanted determinants and about joined up care, and I think that was very well illustrated there in what a difference those approaches the right approaches can make to somebody's life, and about how we as essentially a healthcare organisation cannot be siloed in the work that we do. I think we all understand that, and we're working towards doing things very, very differently, and it's reflected in our objectives. But that story, I think really did help to illustrate that at a personal level, the difference it can make to somebody. So I will take any comments everybody wishes to make some on that. If not, we will move on, accepting that as something to sort of be as our baseline to ground us for the work of the rest of the meeting. Okay, nobody's offering comments, so we'll move forward. That keeps us in the public and patient section. So we're into public questions and answers. We have questions from two members of the public. The first set are from Mr. Gus Cairns. Nori, I think you said you might be able to put this up on a slide. Thank you. So these questions are on the forward plan, and near the last page, you've forgotten the quarterly Transforming Care report. It's question 2 on page 162. Who is going to be on the Cheshire Engagement Reference Group? Question 3 on page 165. Why are people communities right at the very bottom if we don't matter? Question mark. And I'm hoping with Gus's Mr. Cairns' agreement, we will take each of those questions on the agenda, because each of those items, of course, is an agenda item, and rather than answer those questions out of context, we'll answer those as we go along, and I will endeavour to make sure that we specifically address your questions in those agenda items. For the second set of questions from Denise William Cox, and the questions are: many CCGs are advancing plans to centralise services for patients using our urology appliance, such as catheters, with aims of improving patient experience, ensuring patients have an annual review with a nurse specialist, and containing costs. What are your plans around addressing continence spend and improving outcomes for patients? Who will be leading on this? And we have prepared a written response, which we will communicate and will be included in the notes for this meeting. But I believe Tracy Cole are able to give us a summary of that response.
Thank you, Dr. Wilson. So to introduce myself, I'm Tracy Cole, Director of Strategy and Partnerships. And as you say, we've got a response ready for Ms. Denise William Cox. So thank you to her for that question. The answer in short is that NHS Cheshire CCG would lead on that piece of work to review the way that plans are in place for those that receive urology appliances. And so work is underway between two teams within the CCG and other associated partners. So that's the Thriving and Prevention Programme, along with the Medicines Management team. The team is reviewing, as per the commissioning and contracting intentions, the way that urology appliances are prescribed, and they're looking at national models and also working closely with local colleagues who have also been through this process, and in particular Liverpool CCG. So I think that's enough to say in response to that question, and there is a fuller written response available as well.
I was complying with a request to mute. Thank you very much for that, Tracy. So, as I said, a written response will also be forthcoming about that item. That takes us on to the next section, the Chair's report. And I'm always pleased to get over the first part of the governing body, because it just feels like I'm talking for about 20 minutes. But we are on to the Chair's report, which is on page 24 of your pack. So there are a number of items on the report. I'm not going to go through every single one in detail. The first item is details regarding the membership arrangement and about the formation of our Senate meeting, and the fact we do have a plan for our first Senate meeting in the next month. There are two appointments that we need to discuss regarding new appointments from the governing body. One is, sorry, my screen keeps jumping around. An executive corporate board level lead responsible for tackling and reducing inequalities. And you can see from there, and you'll know from comments I made earlier, my suggestion is that Claire undertakes that role, and with your permission, we will give that role to Claire, and we will inform NHS England and improvement of that appointment. So I'm going to pause in case somebody wants
Andrew,
to.
Can I just come in there?
Please do.
So we're happy if the governing body support that, to take that. We did discuss, obviously we have two directors of public health on the board, and whether they should be the, or we'd ask them, but obviously because they cover one of the local authorities each. So what I'm intending to do is work very closely with the two DPHs on this on behalf of the governing body, and I would ask whether any GP might like to be a GP governing body champion to work with myself and the two DPHs.
Okay.
So Mike's put his hand up, which is great. Thanks, Mike.
Right, okay. It's difficult to see everybody all on the screen at one time, but that was, if that was Mike volunteering, that's good.
That's great. Thank you very much.
Thank you very much. Okay, so we'll take that we are appointing Claire and Mike as the GP representative on the governing body. Also in the report, there's a comment about a video by Dr. Owen Williams. It is worth looking at. It's very short. It's under 2 minutes, so I would ask you all to find the time to have a quick quick look at that. The second appointment we have is for a Freedom to Speak Up Guardian. It previously has been undertaken by Paula, and the feeling is this should be sitting with one of our lay representatives on the governing body, and the suggestion is that Peter would undertake that role for us. So again, looking for approval of that appointment. Okay, I can see nodding. So thank you. I think, well, Peter, congratulations. You're now Freedom to Speak Up Guardian, which of course is an important role, ensuring that people within the organisation they have that mechanism to raise what they need to and speak up when needed. The other thing in my report is regarding the governing body development. Of course, members of the governing body are aware of the development that we've been undertaking, but that it's there for the record. I think it's probably also worth saying I've been in discussion recently about discussions we had at our last governing body meeting, which includes in the minutes, about a governing body development session around equality and reduction of inequality, and I'll be discussing that with Claire and Mike, and I've already been discussing with Matthew about how we take that forward for a future governing body development session. Item 4.1, integrated care partnership engagement. We are endeavouring to get board to boards with both of the integrated care partnerships. It is proving difficult.
Okay, Andy seems to be having a technical problem. Is there anyone who could take over chair?
Mike, as Vice Clinical Chair, can you take over, please?
I'm just getting off mute, but yeah, try and pick up where Andy. So we just finished talking about the government development sessions and where we're all aware of that, and it was on the record. And again, oh, Andy, are you back now?
Am I back?
Yeah, you're moving again now.
Right, lovely. Sorry, I don't know what happened there. It said it was a speed problem, but no, certainly beforehand I had 60 megabytes. So anyway, I've just got to find myself. I've completely lost my place now in the.
So you were on page 27. You were just in the integrated care partnership engagement.
Yeah, thank you very much. So is that where I disappeared? Was it the integrated care board to boards? Yeah. Okay. So yeah. We did think we had the 24th of November. That looks like that probably won't go ahead because of more clashes, but we are endeavouring to get that in before Christmas and seeking a date with Cheshire East Integrated Care Partnership as well. And then there's some details of my diary. So most of that is for information. There's just those two appointments which I was seeking governing body support for, which I believe you supported. So I think thank you for that, and we can move on. And thank you, Mike, for taking over temporarily.
Chair, Sir Dr. McGregor-Smith here. Can I just ask two questions?
Oh, sorry, Fiona. It's multitasking. I can see you have put a request in on the thing. Yeah, please do so. Go ahead.
There are two things. One, I think also this has just been slightly highlighted, but I think the board-to-board meetings would be very useful. But my plea would be to keep the agenda items to a minimum, because I can't be the only one who finds this difficult when we're not actually seeing people in person, and if there are other board members that we don't know, it's sometimes a bit difficult to actually get a real feel for what people are thinking or their direction of travel. It was just a plea, really. And the second one was on your item about the chair's diary. I see that you do speak to chairs over quite a large area, and I wondered if there was any feedback that might be of interest to us, and in particular about the discussion that was being put about Cheshire and Merseyside on the last, you know, on one of the latest bits of information that was put out.
So I'm sure that in many of the discussions I have with the chairs, there would be a great deal of information that were of interest to you. Some of those discussions, large parts of those discussions are strictly chair to chair and Chatham House, and we've agreed not to disclose all of them. So I can't reveal everything that's said, unfortunately. With that specific item, yes, there certainly have been discussions, and there are things largely in the quite large items in the public domain about the national requirement, which has been a requirement since planning guidance now for some time, that there is one CCG per ICS. And of course, our local health and care partnership, which is geography of Cheshire and Merseyside, is due to become an ICS in April. And therefore, there have been discussions about what should be the geography of CCGs across that region. There are no discussions, but there is an agreement to have a dialogue about what the best way forward is. So certainly there is no decision that there is a Cheshire and Mersey CCG, but there is planning guidance that suggests that would typically be the case, and that's the wording in the guidance, typically be one CCG per ICS area. What we have had is that we should be exploring with our organisations what commissioning may need to be done at a Cheshire and Mersey level. Now, of course, we already have a forum for doing collaborative commissioning, which is the collaborative commissioning forum across Cheshire and Mersey. And so we already have a mechanism to do that. And that, I think, is the next step. Does that need to be strengthened? Do we need to be thinking about a more formal mechanism to allow us to commission at a Cheshire and Mersey level when that makes sense? And there are some things for which that does make complete sense. Beyond that, there's no agreement on anything further beyond that.
Andrew, could I just,
Mm-hmm.
sorry, I'm not sure how to put my hand up in the box system. So we had a couple of press inquiries about this. And so the Healthcare Partnership have issued something which we can share with everybody. I think that would be quite helpful, that they have issued for the Health Service Journal, that asked for a quote from Cheshire CCG and some of the other CCGs across Cheshire and Mersey. It's very similar to the letter I responded to the two councillors from Cheshire West and Chester who sent me a query a couple of weeks ago, which I discussed, I think, with you all at the informal development session. So we'll share the Healthcare Partnership response to the press queries about that. I think that's quite a helpful update.
Thank you. Does that answer your question, Fiona? Yeah. Lovely, thank you. So if there's no further questions on the Chair's report, we'll move on to the Accountable Officer's report. And this is in two parts, one of which is for information, one of which, was it still? It was.
It's all report. All one report.
It's been changed. So I'll just hand over to you, Claire, and let you present your report. Thank you.
Okay, thank you. So there's an awful lot in this report this month. You can see that because it covers the period from the last formal governing body meeting in June to the present. And as you can see, it covers a lot of information that's not presented elsewhere in the governing body papers. I think it also demonstrates, or I hope it does, to the governing body just the enormity of our role and responsibility as a statutory partner and a statutory leader in Cheshire and Cheshire and Mersey in the Northwest. Early in our days, in terms of the case for change for merger, we talked about becoming a strategic commissioner and supporting the ICP's development. We're actually now in a position to start discussing that formally, and I think that's really positive news, because this is about being the advocate for the 770,000 population in Cheshire. I do think that the Accountable Officer report today, plus a number of the other items on the agenda, really demonstrate the progress the CCG has made over the past 2 or 3 months, and that's at the same time as we've been managing and supporting the system during COVID. I'm going to pick out some highlights. I'm not saying the things not a highlight, things are not a highlight, but it's just such a long report. So I'm just going to pick out some key issues, but very happy to answer questions on all of it. I'm not going to focus on COVID because hopefully Ian Ashworth's going to be here later and he's going to do an update on that. But you can see that, as Andrew said, COVID is still an issue. We need to be vigilant. and there's an awful lot of work still going on across Cheshire. You can see in terms of our EPRR, Emergency Preparedness Resilience Response, we still have to do this, and we're going to be bringing an update in October's paper. Yesterday, Andrew and I were at the Cheshire West and Chester Health and Wellbeing Board, where we received a consultation document around the Joint Carers report. That was really positive, and we're going to hear that at a later date in the governing body. I think you'll be pleased, like we are, that the short break service at Crook Lane has been reintroduced. You remember we brought a paper on this earlier this year in terms of it having to be suspended due to COVID, but pleased to announce that it's been reintroduced from the 1st of September. Clearly, it's not as full a service as it was before COVID, but we're getting there gradually, and CWP, Cheshire Rural Partnership, are working closely with the families. I think it's really positive news. Despite COVID, we've been able to support the introduction and development of a new West Cheshire Autism Hub. I think this is really important, that service developments are still continuing at a time of a national pandemic. On page 33, I'm just going to raise a couple of issues about services. So you'll remember, again, we brought information about the closure of the out-of-hours service, the suspension of the out-of-hours service at Victoria Infirmary in Northwich. There's more information about that on section 9, and also around future developments of the Victoria Infirmary. And I think there's some positive developments going on that the Mid Cheshire Trust, the local authority and the CCG are discussing. Item 10, this is important. I'd like to thank Paula for all her work on this. She's been outstanding in her commitment and support to the Trust, but also to the ladies and mums to be in Eastern Cheshire. So you'll remember in April, we endorsed a decision made by East Cheshire Trust to suspend intrapartum care at Macclesfield General Hospital in a response to the COVID pandemic. This was purely made as a response in terms of patient safety and the Trust's ability to support mums to be. The Trust Board on the 6th of August discussed this again, made a decision to continue that suspension until the end of the financial year. This is another continued safety issue, but also to give some certainty to the mums, because they were beginning to question about should we book in to have our babies or not. And we wanted some sort of consistency and some certainty. We've been working very closely, and as I say, Paul has been outstanding in this work. So we're working to see what happens at the end of the financial year, but we will keep the governing body informed of this all the way along. So I am asking at the end of this item that you endorse that decision, please. We'll be bringing next month an update on climate change, which I think is absolutely right, considering we were the first CCG in Cheshire and Mersey, and perhaps in the Northwest, to treat climate change as an emergency at our first governing bodies in common in January. Seems a million miles ago, doesn't it? Just to remind everybody about the AGM next week, the annual general meeting. I'm sure you'll all be there, riveted by the presentations by myself, Dr. Wilson and Linda on last year's developments, and obviously the CCG will be hosting this event really on behalf of the former 4 CCGs. It's a look back for 1920, but also an opportunity to look forward to 2021. And we will be discussing our strategic objectives, subject to you endorsing them later on. Just a bit of update on our staff. We are continuing to work with organisational development, do some excellent work, and tonight I'm launching the Compassionate Inclusive Leadership Programme in Cheshire. This is for clinicians and non-clinicians, and this is a further development of our Leading Change in Cheshire programme last year. We're going to do some work through the NHS People Plan, and Matthew will be working on this around equality and diversity. We've done all the appropriate risk assessments across the organisation, but we'll be bringing further information about that next time. You will have all heard about the 111 First programme. This is launched in Blackpool already and in Warrington, and Mid Cheshire Hospitals Trust is the first trust in Cheshire to be launching this, and that will be next month. and then the Countess of Chester and East Cheshire Trust follow shortly thereafter. It's very much about patients, it's sort of focused primarily around COVID in terms of not wanting patients to be waiting in A&E, but it's about ringing up 111 and booking yourself in to have an appointment in A&E to support the flow of patients and their safety. I couldn't ignore the fact we've won an award in a Health Service Journal Value Award, and this is outstanding work that we did in our predecessor organisations with Cheshire Royal Partnership about redesigning mental health services. So delighted to receive the award. I think it's a couple of weeks ago now, and you can see in 19.3 where the judges praised the great evidence of co-production and patient engagement. And I think that's timely, considering we've got the engagement strategy on the agenda later. And I know Chris, our co-opted lay member, is a passionate advocate of co-production, so hopefully he can support the work we're doing and is really pleased to see that. You can see in section 21 there's a list of decisions made through the executive team under the executive's authority. I'm not proposing to go through those, but very happy to answer any questions and detail anything about that. Section 22, now I just want to, because obviously this links into section 23 in terms of proposals to revise the standing orders. Under the CCG's constitution, we can, where necessary, take urgent decisions outside of a governing body meeting if we follow all this due governance. We had to make 4 urgent decisions in between governing body meetings over the past couple of months. These have been COVID related in terms of making urgent decisions around additional funding to support our population. They're detailed in 22.2, and again, I'm not going to go through the detail, but can answer questions on those. They were chaired by a governing body member. Either myself or Andrew was there. Obviously, where Andrew was perceived to be conflicted, he stood away from those meetings, and we had appropriate governance around those. So decisions were made, and we're asking the governing body to approve those, endorse those. So section 23, this is, I think, to clarify the governance around those decision making. You can see that we followed due process, but to reduce any ambiguity around the wording of emergency panels and urgent decisions, what I'm recommending is a change to the standing orders. You can see in 23.1, what we're proposing is to add the words in blue and remove the words in red. So you can see there in 3.8.1 of the standing orders some of the changes, and again over the page for the next 2 sections. Okay, so I'm asking that you approve the proposed amendments to the Constitution. They're not significant, but it will reduce the ambiguity around having to the Constitution in terms of making these urgent decisions outside of the governing body meetings. Within the Constitution, we have to report to the governing body the first meeting thereafter, which we're doing today in terms of the formal meeting. But this just clarifies, I think, some of the language within the Constitution. And what I'm also proposing is, because they're not material, the changes, that we don't have to then report to NHS England an improvement, the changes to the Constitution. If you remember, in terms of sort of my role, I can make proposals to change the Constitution. If it's not material, we don't have to then report to NHS England's improvement. So that's what I'm proposing. So a bit of governance at the end of the report in terms of the exec team's decisions and then the urgent meetings. But I hope you'll see throughout the report there is some outstanding work going on across the CCG, and I think you'll hopefully realise that as we move forward through the agenda, we are beginning to move forward as a strategic commissioner. I'm really pleased with the work that's going on at the moment. It's really beginning to feel like we're an organisation sort of leading from the front in the system, and that's what I think we all committed to when we sort of wanted to have the merger of the 4 CCGs into one. So I'll leave it there, Andrew. Thank you.
Thank you very much, Claire. So we, before we actually look at the decisions on those papers, we have got some questions. So I've got Mike and Fiona. So Mike, do you want to go first, please?
Thanks, Dr. Wilson. Dr. Mike Clark, GP representative on the governing body. Two comments. One is on page 32, section 7. So the Autism Hub, very supportive of the work they're done over in West Cheshire and Chester. And just trying to understand what the equivalent would be. So I'm thinking about equity, but what the equivalent would be over in East Cheshire. Do we have an equivalent service there or plan for an equivalent service there? That's the first point. Second one on page 36, section 17 is just as we roll out 111 first. I did mention this in the last meeting I was in, which is we just need to be mindful of the activity that's coming to primary care from 111 and just keeping an overview of what that activity is and whether it's the right activity that's coming back to primary care if activity does come back to primary care. So just really an understanding that we're keeping an eye on how that is rolling out and how it's impacting on the system.
Okay, so could you answer the autism question first, then I'll do 111, please.
Yes, happy to answer that, Claire. So it's a really timely question, so thank you for that. At the moment, we have the opportunity to bid for further funding under the Cheshire and Merseyside Transforming Care Programme strategic pot of funding, and so bids are being put together now. And I think that we would be interested in seeing what the further opportunities are for developing autism support outside of Chester as well. So that's something that we are looking at. But also I think it's about making sure that at the moment that service is virtual and it's launched because of COVID, and hats off to those that have been involved, many others other than me, who've been involved in a lot of hard work to make sure that the Autism Hub is available, even though at the moment the premises in the Blue Coat in Chester are not available. So I suppose it's about making sure that we've got virtual support that really doesn't matter where in our Cheshire footprint it is, that people can still access it as well. So more to be done on that, and that'll be part of our commissioning and contracting intentions going forward as well, Mike.
Okay, thanks Tracy. And I guess in terms of 111 first, Mike, I mean, it's still early days because obviously Blackpool only went live about 3 weeks ago and Warrington last week. So it's a question of lessons learnt and building on what's happened in those pilot sites before we move into mid-Cheshire. Clearly, it's not an acute service, an acute provider and an ambulance service. It's a whole system response to urgent care. So I think you're right, it's really important that we work as a whole system on this to make sure that patients flow to the appropriate place and are not diverted back to general practice inappropriately.
Thank you very much. Fiona, I think you have some questions.
Hi, yes. So Dr. McGregor-Smith. So actually one of them was about the NHS 111, that was exactly it. An additional point on that was that I did speak to people in our PCNs, and this isn't a CCG problem, but they weren't really aware of it going to be happening any sooner than we all were. And I know Leighton Hospital is going to be, is the next hospital to be taking this on. And so there was a concern that that hadn't been discussed with the stakeholders. And as a CCG, we've always prided ourselves on trying to involve stakeholders, and we felt that that from on high this had come down without any particular involvement of the stakeholders, as in primary care, who might end up sort of needing to pick up some of the pieces. The other, so on that, and this kind of leads into one of the other points, although Andrew, thank you, did mention it right at the beginning. I felt again to do with communication, the media comments about GP practices not being open, etc., was very unhelpful. I did read the letter that came, and of course it hasn't got that tone at all. The tone was very much, I think, what GP practices in Cheshire were doing anyway, and so I would just like on behalf of myself really to say that, you know, we are very well aware that the GP practices were not shut. They have been working, and I felt that the tone of the media was particularly unhelpful there. And as regards the things that you wanted us just to approve, I am in principle fine. I just had two queries. One was partly the summer, partly COVID, but there were several, and so I think they all needed doing. They all obviously needed doing, but I think we should be highlighting to the membership practices that they have been done, and I'm sure they go out in some sort of communication, but I'd like to see that. Really, if we're making decisions outside the governing body, we should really flag that up so that there's no question that we're trying to make decisions. So it's just a kind of an over the top transparency really. And then my question was about 3.8.2. So I may have misunderstood this, but in the past, was it not that if we were in an emergency, it needed both the CCG chair and the accountable officer, and now it just needs one? Have I misunderstood that?
Hang on.
Yeah, it was ambiguous, I think, previously. Different people read it in different ways.
Yeah.
But yes, it was ambiguous, and now we're saying it can be either myself or Claire. But if it's whichever one it is, we have to speak to two other governing body members. And,
right.
Okay. I think Fiona, a good example of that was around the decision around phlebotomy, because Andrew as a GP would be conflicted. So having the or meant that as long as I was part of the panel, the decision was good.
So my question is, so I think that's a fair enough point. So, but my question then is, was it not, did you, in the past, could it be the chair and the accountable officer together? Did they have to involve other governing body members? Did they have to involve two other governing body?
Still two other governing body members, yeah.
So
yeah, it wouldn't have just been me and Andrew on our own deciding. It would sit within the normal governance of the governing body.
Right. I mean, this may not work terribly well if there's confliction anyway because of the number of GPs, but I just wondered whether the number shouldn't be the same. So it could be either or and three others, which could of course be the two of you and two others, or you know, we seem to be reducing the number of people as well as the elevated status of the people who are making the decisions in an emergency was my concern.
Okay. How do others on the governing body feel about that? If we were making an amendment to the, or suggesting an amendment to the Constitution, we need to be confident. So we could rewrite it to say three additional governing body members. So myself or Claire speaking to three additional governing body members. It hasn't always been easy to get to at some of the short notices that we've had with some of these decisions.
And I think it's clear in terms of 3.1.8, the addition of normal quoracy rules still apply in order for the governing body meeting to proceed and undertake its business. And because these are decisions around finance, Linda, who is the other exec director who sits on the governing body, Linda has always been part of those decisions. So actually it's been Linda plus two others. Matthew, you've got your hand up, don't you? Through Andrew.
Sorry, Matthew, do you want to speak in?
No, that's fine, Andrew, thank you. Matthew Cunningham, Director of Governance and Corporate Development. So just to answer a little bit around Fiona, so it's at least two of the governing body members, so it could be more if the chair or the chief officer thought they needed to speak to more than just two, and the breakdown of that. I think the other key point to make is that it is for urgent decisions. So if we need to make decisions outside of a formal governing body meeting, then you can do that by other means if there's enough time. But if it is an urgent one, and taking on all the points before around availability and the speed to get a decision back, because often it's an external pressure, then there does need to be this ability to pull together, in effect, this group of people to help with that urgent decision. So I still think at least 2 is probably flexible enough, because it is an urgent, as in we need to make it pretty quickly, not in a week's time, because if it is in a week's time, you can do all the things to get a decision from all the governing body. Again, if you start increasing the numbers, then you might as well have more another governing body meeting. It is just whether you wish to be prescriptive about which other governing body members. But I think at least 2 gives you that flexibility, as Claire's talked about.
Yeah, can I make a suggestion? Because I think this would be good practice anyway, which is one, if we're making decisions, any papers on which those decisions are made are distributed to all governing body members once they are prepared and distributed to those that are going to be on the panel, that the invitation is open to any governing body to join an emergency panel, but that essentially the chorus of that panel is either myself or Claire and 2 other members of the panel. That might complicate your decision making on there, because at the moment it says that decision making is and seek agreement of 2 others, which wasn't in the previous iteration. So it was possible, Fiona, for myself and Claire to speak to 2 of the people who disagreed and then make the decision anyway. But that's now clear that that's not, you can't do that. So would that be more acceptable to?
Yes, I think, I mean, I get it that that if it's an emergency decision, it needs to be made, and it needs to be made quickly. And believe me, I'm all for not dragging your feet. I just thought that there did seem to be a bit of a change here when I was reading it. And so, again, from a transparency point of view, especially if we're not submitting it as a change of material change, then I just wanted to be absolutely clear that we all felt that this was reasonable. And again, this isn't about the personnel involved now. This is about personnel who might come at a later date, that they will also be bid by this, because we know that people that you can trust, but then you don't know who's coming next. Okay, so this has got to be, it's like a partnership agreement. It's got to be resilient to the future, and that was my question. And so I'm happy if everybody else is happy, having raised that issue, that's what we do, and it has to be agreement with 2 other governing body meetings, governing body members. And I'm going to say this because it doesn't reflect very well on me. I have never seen these papers. They've probably been sent and I've ignored them. But is there a bit on it that says the reason this is an emergency decision is? Because that's the thing that needs to be absolutely clear, doesn't it? In which case, if everybody else is happy, then I'm happy. I just wanted a bit of a feel for it.
So absolutely, Fiona, there is, and I can assure you that the decision that I was at, I think 2 that I was at, one that I left when I realised I was conflicted. That was the first question that was asked, and there was the ones that I've been present at, more robust discussion than there probably have been at ordinary governing body meetings. I think because people are feeling that it's an emergency decision and that it's an emergency governance process, it's been and certainly Peter and I were on one together, and I think we gave the officers presenting a fairly hard time about why was this coming as an emergency, and I think we certainly did our scrutiny on it. I think so. Just to ensure they're not sort of rubber stamped. I think certainly when I was involved with Peter, we felt that we needed to make sure that we were making a robust decision.
And Fiona, I mean, this isn't normal practice. This is sort of in light of COVID. The decisions are about increasing capacity and services in response to the pandemic, and there were also, external timelines that we were having to respond to. Something that wouldn't happen under normal circumstances, and we would manage it through our normal governance in terms of finance committee or strategic commissioning and performance, then up to governing body. This was a sort of these were 4 cases, and it sort of come closely together, but it was a needs must in order to keep the services running or to make sure we met national deadlines around funding.
Okay. So are people content that we agree, well, it's for Claire to propose them, Claire to make them. So I think, are we content with the suggestions that are being put forward? Dr. Rees.
Hi, Gwydion Rees, GP representative. I think it all sits really with 3.83 and what we actually mean by ratification. So for me, that's quite an important distinction, because as long as we have an open and transparent method, I'm happy. But the ratification aspect means that when it then comes to the governing body, we actually sign it off and continue that decision as being valid. Whereas I'm getting the impression that we're saying that if a decision is made, that carries forward, which doesn't involve ratification. So I think that's where it sits, actually. So
yeah, to be clear, what the emergency section of the allows is essentially for the full decision-making powers of the governing body to sit with that smaller number of people. So essentially, what's happening is that this meeting we're being reported a decision that in effect the governing body has made, because it's made it under its emergency procedures. So I don't think, and I'm looking particularly at Matthew, I think at the moment, if you all completely objected to the decisions that have been made on those emergencies, they can't be reversed because they've been made under the due governance of the governing body. That's my understanding. So Matthew, is that correct?
That is correct. You wouldn't in fact be reversing a governing body decision. The key bit in terms of what Gwydion's saying is we need to report this in a public domain, which normally you would have if we were having this conversation about those decisions in a paper at a governing body in public. So that's also the purpose for the ratification and Claire reporting it, is that we've also got that sort of transparent trail around the decisions that have been made. But just to confirm, under the Constitution, you have delegated that authority to that group of people as the governing body.
So I think we need to be very careful that we only use those procedures when it's absolutely necessary, when there's not another option, such as calling an emergency governing body meeting. So I think it's right that we see them, that we can challenge as to why that these procedures were being used, and we can see what decisions have been made to ensure that the decisions aren't being made which are out with what we think are reasonable by that emergency procedure, which is the reason that they're reported here. So if people are content, I think, sorry, we've got a further question from Peter, I think, and then we'll just tie up the paper. So Peter.
Sorry, thank you, Dr. Wilson. Peter Monday, one of the lay members for governance. It actually relates back to 4.4, not the issue about the urgent decisions. On 4.4, there's a reference to something coming back to the governing body in October, and I think Matthew's pointed out to me that that's actually should be November. 4.4, there's the statement of assurance will be approved in November. That's correct, Matthew?
Sorry, just taking my mute off. So yes, due to the timing of what we need to get assurances back to NHS England, it does need to go to the Governance and Audit Committee, and then the next meeting, the governing body, I believe, is now in November. So it's to the next meeting of the governing body we'll report back.
Okay. Now, just on that subject, I realise it's probably outside the scope of the NHS England letter, but probably not outside the scope of this governing body, is that given that we're talking about this winter coming, whether we're reflecting the things that may happen if we have a disorderly Brexit. Given that we had this time last year, I think it was, we were carrying a risk, corporate risk for a no-deal Brexit. I think we're almost back in the same territory. Now, whether we provide that assurance back to NHS England or not, I think as a governing body, if you're looking at the things that could happen this winter and coming back to the governance audit and risk committee, I think we probably need to include that within scope.
Andrew, if I can just answer that, we've covered Brexit within the winter plan, which is a single system winter plan, and we are developing a single Cheshire A&E delivery board, which will oversee and be accountable for the delivery of the single winter plan. But that does include Brexit. And that plan is going to strategic commissioning and performance next month. So we can bring it back in terms of some of the risk, Peter, but we have included that as part of that winter plan because of the timing of it.
Thank you very much.
Okay.
Sorry, Matthew.
Well, it's okay. Just to add a bit more. So we've just been contacted by NHS England that are going to outline a bit more detail about Brexit. So I think we'll be able to update you a bit more fully in the coming weeks once we hear back from NHS England as to what they also want us to report on in relation to Brexit going forward. So it is emerging again, Peter.
And we've got to re-identify our Brexit SRO as an organisation. So.
Okay. Thank you. If there are no further questions, I think we have concluded the Chief Officer's report. And just for clarity, we're asked to note the contents of the report to ratify the urgent decisions which have been made, which I believe we've discussed, and to consider the proposed revised CCG standing orders outlined in section 23, which I also believe that we have done, and I believe there is acceptance on both of those points. That will take us on to our strategy and business items. And if I can just point out to members that we are unfortunately running some way behind. We next have our governing body assurance framework. I think we all agree this is an important and central tool. We also all know that it needs to be updated, and we've got plans to do that, but this remains central to our strategic governance, so it's an important item. Matthew.
Thank you again. So Matthew Cunningham, Director of Governance and Corporate Development. So I will not labour too much more on the assurance framework as you've outlined the importance, Andrew. Just to highlight, as I do each time, any amendments since the last version that you've seen is highlighted in blue throughout the document. One of the key things to note is that there has been a significant rewording of the finance risk, which is Governing Body Assurance Framework 02. However, there is no change in the overall risk score. So just to note that one. If there are any queries around any of the particular risks, then I'm sure myself or some of the risk owners will be able to answer that. And hopefully you've also seen within the report, again, just reconfirming the plan for the next steps in terms of our upcoming workshop, a date to be confirmed around relooking at our sort of risk appetite and how we can then change going forward our risk assurance framework to reflect hopefully our new strategic objectives that we're considering at a later time today. And I'll leave it at that, Andrew.
Very much. Are there any questions? Fiona, can I just remind people to use the chat box to request questions? But Fiona, please go ahead.
Yeah, but this, so I'm not sure in the order to put this. This is the only question I have about the assurance framework. To reassure you, that coming later is going to be the discussion about the options and our direction of travel. And I don't quite know. It's a bit chicken and eggy, but how you. With the financial risk, if part of what our aim is to try and almost devolve responsibility and presumably with it the money to ICPs to actually take on some of the commissioning, I suppose, of local services, how can we do that if we don't actually know how much money we have? Because it says, and I appreciate that's one of our risks, because those things haven't been agreed yet, and that was I didn't quite know where I should bring that question up, but I'll bring it up now.
If I start to answer that, and then maybe Linda, you can come in, please. That's okay, through you, Andrew.
That's lovely, thank you. Go ahead.
Earlier today, Andrew and I had a meeting with the chair and the managing director of Cheshire West ICP, a sort of a 2-to-2 conversation. We were talking about presentation that I was going to take to the ICP board next week, which is very similar to the one that's in the pack today. And I think the key conversation was around an assurance framework in terms of delegation and accountability. As a CCG remains accountable, and if we're going to discharge some of those responsibilities through a different organisation or a different body, we need a very clear line of sight through a sort of an assurance and accountability framework between the CCG and the ICPs. So I think, Fiona, that would be covered up, would cover a lot of the issues you're talking about. Clearly, in terms of financial allocations, the allocation comes to the CCG. If we delegate responsibility to an ICP to deliver something, the budget will have to go with it, but we would, in light of our financial position, set the same stringent quick targets, the same performance targets. We'd only ask the ICPs to do something on behalf of the population if we and they believed they could do it better and more efficiently. So I think it's about a very tight partnership agreement, which is, and a sort of an accountability and assurance framework between the CCG and the ICPs. Okay.
Thank you. Has anybody got anything to add to that? No. Thank you. We have a question from Wendy as well, please.
Yes, Wendy Williams, I'm a lay member. I was just looking at, Matthew, if you could answer this one, I was just looking at the quality and sustainability of services risk that you've put in. And it's a comment really more than a question. The additional blue during the COVID established contingency plans to communicate with trusts on safety and quality issues by exception. And you've added in that you're expecting the directors of nursing sharing trust quality committee papers on key risk matters to provide additional assurance. I'm in touch with a number of different directors of nursing and they are, I think, almost at the point of keeling over with the amount of work that they're currently doing and trying to manage within the trust, especially now that things may be hotting up again, planned care, all the other things that they've got to try and deal with. Are we in danger here of perhaps a little micromanagement by actually holding them to even more account on this, by scrutinising their quality papers? What happens if we disagree with some aspects of what they're doing internally? Where's the trust between us and the relationship, the issues that maybe we may overstep the mark a little? But that's just a query.
So Andrew, I would probably defer to Paula here on this one due to her close working relationship with the directors of nursing for these trusts. But I'm sure I can speak for her and say there's no expectation to add more work onto an already busy. I think this is about good relationships anyway. But I'll defer to Paula on this one.
Paula.
I'm Paula Webb, I'm the Director of Quality, Patient Experience and Safeguarding. Thanks, Wendy. Just to say that normally our trusts already share their quality committee papers with us, so this is the norm. The reason it's been identified in as an additional layer of assurance is the letter that came several weeks into COVID, which was about reducing the burden and increasing the capacity. One of the areas that they said needed to stay intact was actually the quality committees within trusts. So we were in a very fortunate position in that the national direction was around sustaining quality committees within trusts. And so fortunately for us, that was an area of assurance that we relied upon in terms of how we would have that oversight. So I think for us, that was a very fortunate position. So I just want to be really clear that it wasn't a new request. It's part of our quality about how we seek assurance anyway, so that we don't seek separate reports. We review what goes already internally within trusts. and as part of COVID, it was part of the national direction anyway that quality committees remained. And actually what it's done is it's a nod to the fact that in standing down some of the quality and performance contract meetings, that therefore we need to really make sure that we look at those quality committee papers that are going on anyway, and we therefore then target our questions. And it isn't about buttoning people down in terms of, you know, great detail. It is about overview and scrutiny, and actually it then just supports my relationship with the directors who I speak to in turn every couple of weeks. I ask for information by exception after paying attention to the detail in those reports. The feedback I've had from those 3 directors of nursing is that they think it's working really well. And I am on calls with the directors of nursing every couple of weeks. We do them on Thursday evening across Cheshire and Merseyside. We share a lot of our concerns and thoughts and feelings, and they are reflective of some of what you just said, Wendy. You know, this is an amazing group of staff working really hard to make sure that you know, urgent care as well as recovery in terms of planned services are being delivered. So it was really just to draw attention to the fact that that layer of assurance that's normally there is bringing additional assurance while we actually reduce some of the burden of normal contracting and quality processes.
Thanks, Paula. That is reassuring. Certainly, some of the comments that have been made to me have been that obviously NHSI are also requesting more and more detail, and I was very concerned that we're not adding to a burden of lots of different and additional work for them.
Yeah, I guess one of the things that'd be really helpful, perhaps just to feed in here, is that if any of our trusts find themselves in a situation where they have to report additional information to either the in-hospital cell or, for example, through to NHSEI because of nosocomial outbreaks, my agreement with the directors of nursing is that they only copy me in information that they're sharing, that they don't have to provide me with anything else additional. I take that responsibility really seriously, Wendy, in terms of making sure that I am perhaps additional level of assurance as opposed to an additional burden. So I think it's a point well made. Thank you.
Thank you.
Thank you very much for that. I think that is all the questions that are on the GoBAF. So we are asked to note the updates and the contents of the Governing Body Assurance Framework. I believe, looking at faces, we are happy to do that. I see nobody objecting. Thank you. That takes us on to item 4.2, which is our strategic objectives. So I think this is quite a step forward for us. It is significantly later than we would have liked it to have been, but of course, COVID has put a number of things back in our timetables. But we have got to the stage of having strategic objectives to present and hopefully to agree. So could I have the next slide, please, Noreen? So this slide illustrates the process that we've been through in quite a short timescale to get to the point where we've got to. So you see that it has involved a number of people sitting around the governing body table, or most of the people sitting around the governing body table at various stages. And so I think it's been quite a good process, and hopefully we all feel that we now own this. So can we go to the next slide, please, Noreen? This is probably the key slide, which is a sort of the sort of a plan on the page of our strategic objectives. The 4 major objectives sat in the centre: improve wellness in our communities, high quality services for anyone who needs care, equity and equality in health and care, and financial sustainability and good governance. And then you'll see around further granularity around those 4 areas. And then down the right hand side, our CCG values: care, courage, compassion and challenge. And down the left hand side, some sort of pillars, principles of our approach going forward around population health, about being an innovator in commissioning, about fostering co-production, which we've already heard about today, and we'll hear more about when we talk about our strategy later, and about bringing innovation, evidence and thinking, the best innovation, evidence and thinking into Cheshire. Next slide then, please, Noreen. So then you'll see that each of those areas has then been in more detail, taken forward in more detail, which to give areas of delivery for each area. I don't intend to go through each of those, so I know that you will all have read them. What we're looking for from you today is any final comments or observations, and then seeking support and approval of the strategic objectives. I think this is there's two things I think about the strategic objectives. One is I don't think we should think that they are set in stone. We will continue to learn, and we will need to continue to change our strategic objectives to make sure they are fit for purpose. And I don't think we should be scared to do that. But I think it is right that the organisation needs that sort of starting point to know what it is that we as the governing body are saying we think needs to be delivered. Problem is now clearly there needs to be further work. Some of that will be our refresh of our governing body assurance framework, which will reflect these strategic objectives and our delivery all against them, any risks around those delivery against them, and then course further on into our commissioning intentions and plans, and then objectives and plans going forward. So there'll be a cascade then of things that need to come forward from this, which is going to take a number of weeks and months to come to fruition. But this definitely is the starting point. So before I open to questions, I just want to say thank you for everybody that has been involved, the work that has taken us to get to this point, in particular Dawn Scott, who helped significantly to sort of I don't know what the right term is, coordinators. I think let's go with coordinators. The politest way is probably coordinators to get this onto the one page and get something in writing which is helpful. I know that people have commented to me that they are how pleased they are with these objectives, and I'm hoping that they will be well received, but not just within the organisation, but also amongst our partners, because I think they are significantly different from objectives that CCGs, our predecessor CCGs had previously. Right, I'm going to go quiet now and take any comments. I can see that Claire wants to come in. So Claire, do you want to make a comment, and then we'll take any further comments?
Yes, so thank you, Andrew. I think it's just to commend these to the governing body. I think we've made great progress over the past few weeks and months. I'm really pleased and proud of these. I think they feel as though they feel part of Cheshire, really, particularly if you sort of couple them with the vision and the values. I think that plan on the page is a really strong, calling card really for Cheshire CCG, the ambition we had as part of the merger, sort of be a strategic commissioner and to move forward on behalf of the population. So I'm really pleased with them, and I think they'll be a great help to the organisation in terms of future planning. Thank you.
Claire, just before you finish, we've got a question, which is what are the next steps on this and to make it more visible to stakeholders and the public?
Well, there'll be work through, I think one that I would want them to go through the internal, and I can't remember the group, it's called Staff Engagement Champions. I think there's something about embedding them with our staff, clearly through the exec directors, the director team, but through the staff engagement champions who've worked on the behaviour charter and the vision and values. I think that's a perfect group for the internal work. We'll then do some, if I'm honest, Andrew, I think we'll probably just do some comms, some communications out to our stakeholders and say we've signed these off. They are a moment in time, but I think they're the starting point for next year's commissioning and contracting intentions. There are 3-year strategic objectives, and that's the whole point. It isn't so we don't have to keep repeating them. So I think these are the starting point of our planning going forward. So we'll do some communications. We've got ways of doing that already, and we'll use the building block with our meeting with the Senate and membership next month, and then there'll be the starting point for the commissioning and contracting intentions for next year.
Thank you very much. Any comments upon them? Any last minute observations? Okay, so I will just add, I think from what Claire said, being proud of these. So I think we should be proud where we got to with some of the elements that we've got in here. about actually approaching our role as commissioners quite differently. I think it's right that we'd say that they're a start of a journey, because we know this is a journey of becoming strategic commissioners that we are going to learn as we go further on. But I think we have managed to encapsulate within these strategic objectives some very important aspects, and that can make a real difference. It's sometimes difficult, I think, to think, oh, we're going to become strategic commissioners. We're going to be more distant from the population. How does what we do even matter to the population? But I think it absolutely does, because if we don't set the right environment, if we don't get the contracting right, then the people in ICPs and in other providers simply can't do what they need to do to the fullest extent with which they can do it if we get our part wrong. So it can sometimes seem a bit distant, but I'm absolutely passionate that actually we massively need to get our job right so that others can do their job properly. So I've got no further comments. So we are asked to note the process and approve the strategic objectives for between 2020 and 2023. So are we happy to do that?
Yes.
Hoping to see some nods. I've seen some nods. I've seen everyone nodding. We will accept that. Thank you very much. That takes us on to item 4.3, which is the approach to commissioning integrated care partnerships. And Claire is going to start us off on this one, please. Thank you, Claire.
Yes, thank you. I'm just going to do a very brief introduction, then hand over to Tracy for the presentation. And actually, Andrew, I think how you concluded the discussion around the strategic objectives is pretty much what I was going to say in terms of opening this item in terms of, I suppose, the CCG's place and position in Cheshire. I think I referred earlier in the opening in the Accountable Officer report in terms of our case for change or a single CCG was around becoming a strategic commissioner and supporting and empowering the ICP development. And I think we're actually getting there now, and I think we've made some excellent progress over the past few months. This is very much about supporting the primacy of place in terms of integrated commissioning, integrated delivery. But we have to go as an organisation, as a journey behind that. We know we want the two ICPs to flourish, and we have to help them. And this is our proposed roadmap to help them do that. This is very much in keeping with direction of travel of our Cheshire and Mersey Healthcare Partnership. They recognise the primacy of place. They recognise the need for integrated commissioning, integrated delivery, which I think we are leading the way on. I think we should be pleased with that, and I think we should advocate for the population of Cheshire in any discussions we have with Cheshire and Mersey over the coming weeks and months. And I think this presentation sort of sets out where we want to go and how we want to do things. And I think that fits what Andrew was saying in terms of sort of the passion behind wanting Cheshire to be the best, and in terms of the vision, the values, the strategic objectives, set us on that course. So Tracy will do the presentation. There are a number of options that we're asking governing body to consider after the presentation, and there are a number of other considerations around governance and how we approach this. I think we'll be listening to the presentation first, and then we can have a conversation around next steps and supporting the direction of travel. Thank you.
Thank you, Claire. So Noreen is very helpfully sharing some slides for us now, which you have in your pack starting on page 80. Prior to that, starting on page 75 is a report which covers the same information. So they do match up, but I think the slides are an easy way for us to have this discussion. I think before we start, I'd like to do two things. One is just to acknowledge the great work of Amanda Ridge and Richard Burgess. They have joined now, and if there are further technical questions, they're going to assist me, because this is very much their work. But even more importantly, I just thought that the powerful words that we heard from Anthony at the beginning of this governing body meeting almost sum up why we're doing this, which is about us making sure that our services are not in individual boxes, because people don't come in individual packages. They have needs that are holistic, that span beyond just the NHS. So I would ask you to keep that in your mind as we go through these slides. So we'll move forward to the next slide, and I just wanted to explain what it is we're going to go through today. I think it's about providing a background and the overview of the 2 integrated care partnerships that exist in Cheshire. We want to talk through some options and have that conversation that Claire's outlined, then understand the considerations around around those options. And then I will be asking you to approve a recommended option and understand the next steps. Fiona's also alluded to that earlier on today. So the background is coming next. And I just wanted to reiterate what Claire has said around where we're doing this. We asked each of our individual member practices to agree to the CCG merger, and a big case for doing that, a big case for change, drive for us becoming a single Cheshire CCG and moving towards a strategic commissioning place was about the symbiotic development of our 2 integrated care partnerships. And so we've already made this case very clearly. And I think that I just want to remind you of that commitment that we've made to our membership. And so I feel there's a duty bound requirement, but also we've already clearly articulated the case for change for developing our ICPs. Beyond that, in the next slide, we're going to look at the evolving nature of tactical and strategic commissioning. So Claire and heard already about our strategic objectives, which is that if we do progressively develop as a strategic commissioner, we can loosen the grip and the tactical involvement on some of the day-to-day aspects of what we're doing and allow that to flourish in terms of our ICPs. So this is something that is really important that we look at doing hand in hand. We'll keep going, Noreen, please. So in the commissioning and contracting intentions, you would recognise this diagram, which tries to speak to what it is that we mean by being a strategic commissioner. And I think we've heard several versions of what that means, but it's effectively standing back and allowing the organisations to work together by being clear on our expectations, but not meddling and getting as involved in our individual contracts and perhaps monitoring outputs in the way that we have in the past. So within the arms that would wrap around from Cheshire CCG would be those 2 ICPs, and within those 2 ICPs will be a number of separate organisations. And the point of the ICPs is to seamlessly bring together individual organisations so that for patients and members of the public, they wouldn't know the difference between where one organisation begins and ends. I'm sure we've all got examples where there's a handoff of care between different sectors of NHS and social care, which sometimes we lose people in between, and we don't do best by our members of Cheshire. So that's the vision within the commissioning and contracting intentions. Each of our place plans have taken some time to put together, and on the slide we don't need to go back, but just wanted to make sure you're aware that there are objectives from each of our 2 places, and they're very similar, and they also speak to the development of the integrated care partnership. So they're there just for reference point, and I wanted to make clear that we're not intending that they get lost in this development. So thank you, Noreen. On the next slide, the King's Fund have given a helpful definition of what we mean by an integrated care partnership, which I think is about being greater than the sum of the parts, really, and I'm trying to use that language throughout this. So let's just have a look at what we've got so far on the next slide and the current scope. Fairly limited, really, but we have made some progress in, I would say, devolving and delegated the functions that you can see in the bullet points, and there are a number of place priorities. So we'll keep moving through, but at the moment that is quite limited. So just to give the background on our 2 integrated care partnerships, starting firstly with Cheshire East, and you can see the provider organisations in the speech bubbles that make up the content of the ICP in Cheshire East. Along the top, we've got the names of the care communities, which, with the exception of Crewe, map on neatly to the primary care networks as well, and you can see the populations within those. So this is just for information to make sure that everybody understands what we have at the moment. So many people will already know this. Both of our ICPs are similar sizes in population, with Cheshire East being ever so slightly larger. So if we look at the next slide, you'll see the priorities that exist down at the bottom within Cheshire East ICP, and just some of the governance around it, which is that it's only recently established comparatively the host organisation, but we're seeing great developments from Cheshire East ICP, and I think that we want to help that develop, and I'll talk to you in a moment about the options around that. So Cheshire West, on the next slide, we've got the same diagram just to give you a flavour of the care communities that exist within there and the populations that they serve. And I suppose what we're always aware of is that across both of our ICPs, there are areas of major life chance differences and deprivation, and I think when we come on to that, that's the beauty of our ICP, that perhaps some of our commissioning intentions will be around making sure that we focus more on the areas where we know we've got health inequalities, and how we can see the ICP support those areas in more detail. The Cheshire West priorities are on the next slide, and also some of the host arrangements. So Cheshire West's host arrangements have been in place slightly longer, and some of the governance has been there in place slightly longer, but we're also working closely with Cheshire West on seeing that progress. And those slide covered at the bottom shows us some of the priorities that Cheshire West ICP have been working on. So if we keep moving forward, please, Noreen. This is also about health and care coming together, so social care. So the local authorities have been working in partnership with us, and there is more work to do, but the commitment is there that we don't separately commission the same services, and that we come together. And the phase 3 planning letter that has been out and in the public domain, it makes very clear the expectation that we come together even more. So we're very pleased with the discussions that we've had with both Cheshire East Council and Cheshire West and Chester Council around developing that further. And we have had the first meeting of the Commissioning for Integration Executive Board, where we are looking at the governance required to bring together some joint commissioning pilot areas, providing we get approval and support from elected members within both of those local authorities. So the next slide gives us the governance on that, just so you can see. So the big blue box in the middle shows you that board that I've just referenced, and how that will flow through our Strategic Commissioning and Performance Committee subcommittee of this governing body, and then make sure in the monthly update that comes to governing body that people are aware of that. The bottom left box is an ICP development group, so I see this as very significant. It's the workhorse of the group, of the requirements that are needed for this work. So I'll just ask you to bring up the next slide, because that then gives you the content of who's in there. And I think that's quite important, that this is not Cheshire CCG doing things to people. This is about co-producing it with our partners. So we've got members of different parts of our all directorates within the CCG. In the top bullet point, both councils are involved and both our ICPs. So it's about us co-producing this roadmap as to where we want to go across our partner organisations. So this presentation, again, hasn't been put together in a darkened room. It's about working with our partners. So let's carry on, if we would, Noreen, please. So just to put this into flavour beyond Cheshire and Merseyside, what are others doing? And it varies, but you can see some of the examples that we've got at the bottom are from different parts of England, many of whom have progressed some of the joint commissioning agendas and have moved forward on some of the developments around ICS. So just wanted to make you aware that I think we've got those very clear ambitions and strategic objectives that we want to be at the cutting edge of doing the right thing and the best thing for our population. And I think that we need to continue to progress so that we're not falling behind some of the progress that we can see in some of the other areas that I've mentioned there. And I think some of the discussions around how we're working with our local authorities I've just mentioned, but also how we work within Cheshire and Merseyside ICP, the ICS, and also how we use our ICP development to progress that. So on the next slide, we're going to start to look into the options that we've got for governing body to consider. The first option is to do nothing. I suppose I would say, to be quite honest with you, I don't feel that is an option, but I think it's important that we always have that as a consideration. Given the commitment that we made to our membership and that we are already, as a governing body, committed to that in terms of formulating Cheshire CCG, the case for change for developing our ICPs, I think, is already strong and clear. And so if we don't continue, if we did just continue with the current contractual arrangements that are in place for the small services that have been delegated, the ICPs will simply not flourish, and I don't think we would flourish as becoming as a strategic commissioner. So the next slide almost outlines some of the pros and cons of doing that, and I think we need to be clear that Cheshire remains financially unstable without us doing something very different, and I don't think it would address those health inequalities that, as part of our strategic objectives, we said we want to try and address. So I'm quickly going to move on to the second option, which is an incremental approach, which would be around, and we have looked at whether we could allocate programme budgets to our ICPs, which would allow certainly progress from where we are now, and support for place priorities. And there's a strong argument for that, and we'll look at the pros and cons if we could, around, on the next slide, around doing that. That I think we felt that it would help us to start to look at reducing the handoffs between different parts of our services and reduce that clinical variation and some of the inequalities. But it's difficult to precisely identify the funding streams, and also it could result in some inequality. It will also take longer, and do we want to take longer to do something that we know is the right thing to do? So I'd like us to move on to look at option 3, which we've termed the more ambitious option. And this is something that, on the right hand side, we've set some potential key markers in terms of dates. I think there is some flexibility around those, but what we're talking about is aggregated place level health contracts. And this would mean us really wrapping up a great deal of what the current CCG budget is and requirements, and making sure that we have delegated those to the ICPs and transferred over the period 2021 to 23. And once they've been agreed, the delivery model and the options would need to be considered. So just want to go into the pros and cons of that and be really clear what we mean. So this is about integrating locally and making clear that we've got a more seamless model of care, and reducing that inequality. It would allow the CCG to devolve its tactical functions and support the ICPs in their growth. That will mean, and we'll see in a further slide, letting go. So the CCG would need to delegate the responsibility to the ICPs, but be really clear that we need to see improvements. I see no point in us doing this just for change's sake. So I think Claire used the words, we would need to see better quality or lower cost or greater improved outcomes for Cheshire patients. It's no good just doing it because it then means we've ticked the box around moving things into an ICP. And we'll see on a later slide, the improvement and assessment framework, which has then been replaced by the NHS oversight framework for CCGs, sets out the requirements for CCGs. We would be delegating our responsibilities to the ICPs to improve our performance against a number of KPIs which are set for the CCG. So we wouldn't be moving the money without the responsibility. And I think that's really important, coming back to Fiona's question earlier on around financial delegation. I think there is a major change programme that would be needed in terms of doing that, but it would also then allow us to make sure we use a population health approach to address the ways that we are looking at that, so that we know that we can then get under the skin of pointing health and care services to those who are most in need, rather than necessarily reacting to some of the requirements that happen at the moment. So that's the preferred option. So if we move on to the next slide, considerations. It's not a simple process and simple process. So we would have to be absolutely certain that we have appropriate governance in place. I think there's further discussion with GP membership. I think that has happened already in terms of the vote around the CCG, and there's been a great deal of discussion. I think it's been harder due to COVID, but we have meetings coming up, and so we want to use the Senate and the membership to have continued conversation with our GP membership. That assurance and performance framework would need to be very clear, which I've just mentioned, which would be ensuring that the responsibilities are known and that we see progressive improvement, and that the roles and responsibilities are very clear. The financial framework would also need to be in place so that we're looking at system control totals rather than individual organisation totals as well, and I think Linda would probably want to give some more information on that. We have got NHS England and improvement support for this, and we're hoping to secure some further hands-on input to help us progress on some of these agendas, which we hope to bring to a future governing body. I think we need to think about capacity and capability across all of our organisations, and I think the 4 population health petals that the King's Fund refer to is really important. So I'll keep moving, I'm conscious of time. So those are the health petals that I've just mentioned, and it's about how we would want to look at that population health approach. And the next slide then I think takes us to that responsibility devolution, and it wouldn't just be for the CCG. This is about all of the partners and the providers within each of our ICP footprints, which was on that infographic, really looking at how they can allocate resources into the ICP. So it's not just a move of we're not just creating a different CCG, it's more than that. But I think that oversight framework performance targets that are in there are very key to us feeling safe in doing this. So the next slide then, I think, takes us back to the beginning and what I'm asking you to do today. I'm sure we'll want some discussion on this, but really the ask of you in short is to approve recommended option 3. And in doing so, then I would be wanting to establish a governing body executive working group which would oversee this work and make sure that we've got hands-on contact on what we're doing outside of governing body, so that, but also linking back very closely. We will continue to discuss these plans with membership and to work with both ICP boards to progress this and confirm the future reporting requirements. So the next slide just finalises the steps that would be required. And I just wanted to assure you, as you'll remember from previous work that I've brought to governing bodies in the past, for those who know me, that we'd have very detailed project plans, and that those would be brought back to keep you assured as to how we're on track with that and how we're seeking the assurance. So I think that probably says enough for this point in time. So I think it's best if we wrap up there and take any questions if that's what you want to do, Dr. Wilson. Thank you
very much. Thank you. So before we do go on, and I can see there are people who are keen to ask some questions, I think it's important we're clear about what it is we're asking the governing body of today. So clearly this is a fairly large decision, and it's not a decision I think is going to be a one-off decision. So today, I think what has been asked of you is to indicate your ambition for change. Where do you want this to be going? Where should we be heading? What's the aim of this? Rather than saying this is a decision you're going to make now and that's the end of it. So, and the other bit we think we need to come out today is what is it that we need as a governing body across a decision I think is going to take a number of months really to be sure about, is what do we need to see to develop. And I think, Tracy, you mentioned frameworks, and I think, yes, there does need to be a framework between the CCG and ICPs about around assurance. But I think there also needs to be something of a framework, a timeline, a journey that about this decision that's going to go on for a period of time. What are the stop-start positions along in the coming months? What is it? How will we judge our maturity to be a strategic commissioner? You know, what is it? We need to stop and think. What do we need to have in place to ensure that we can become a strategic commissioner? What do we expect of ICPs in terms of how they will be sufficiently mature to take this on at what point? And that may be different in our two different places. What's our framework around how our relationships have developed, and we make sure that we've got the right working between us, because I don't think this is ever going to be as simple as a transaction that can be laid out in a framework. It's going to be multi-layered, it's going to be complex, it's going to be about relationships, it's going to be about reporting in, it's going to be about involvement. So there's lots of things I think we need to think through, which I'm sure you're completely aware of. I know you are, but we need to say these things because it's part of the discussion, isn't it? So we need to see all those things which are laid out, and I think the proposal is that is what a working group might start to look at and say, what is it that needs to be in place in order for this to become a decision that continues. But what we're asking today is, what is our ambition as a governing body? And I think the suggestion is that it should be a large ambition. From knowing you all, I think that is what we expect you to all be saying. But it's right that we have a debate and discussion about it. So I will bring in Suzanne and then Gwydion. So Suzanne.
Sorry, just trying to unmute. Suzanne Horrell, lay member for governance. I think what we're talking about here is our appetite for the speed of change, and I don't disagree with what's being suggested. But my query is, what is the appetite from the ICPs? I mean, we're not doing this in isolation at the moment, but it's okay for the CCG to say, you know, this is our appetite, we'd like to go at pace. But what is the position and the maturity of the ICP to actually agree and say, yes, we'd like to go at pace too? So I'm just wondering what the flip side is from that as well.
So could I ask Amanda to introduce herself and then perhaps answer that question, because she's been linking in very closely with the ICPs.
Okay, thanks.
I nearly started talking there with my mute button on. My name is Amanda Ridge. I'm the Associate Director of the New Models of Care team. So as Tracy suggests, I've been working, myself and Richard have been working very closely with the ICPs and with both local authorities as well. And we've been making sure that they're aware of all of these conversations that are taking place. In terms of their appetite, they are really keen to get things moving. And I think there's almost a sense of frustration that they want to get things moving quite quickly. So I think they're definitely sort of up for this, as it were. Where we are in terms of governance, obviously the discussion needs to take place here first, so that we can be clear from yourselves that you're happy with what level of appetite and pace you're comfortable with, and then we will follow that up. We have a meeting, both Claire and Tracy are going to the ICP boards, both boards, one on the 24th, one next week, and then one on the 8th of October, to sort of have the discussion about this is what the proposal is from the CCG, and then to take their response, and then we'll almost between us work out, you know, what the joint position is, and then take that forward. And again, as Andrew said, we can bring that back to you so that you're getting constantly updated about where things are up to and where the plan's up to.
Okay, that's great, thank you.
Okay.
Okay, thank you. So I think then Gwydion, you had a question.
Thanks, Andy. Great conversation, and following on really from Suzanne, really, I think we need to be brave. And if we are really going to be a strategic commissioner, then we need to pump prime the system and drive it in a new direction. But we need to be fully aware that, you know, our partners in this are mature enough. So I think the timeline to that is really important. But I don't think we can keep doing the same thing. We have to do something different. So it was really making that point, which has already been covered actually.
Thank you, appreciated.
Thank you very much. So that any further comments on, says that there's a sort of substantive issue, isn't there, of what our ambition is, but there are also other things for consideration, which in terms of the formation of the working group, and also I think consideration of what it is that we as a governing body will want back from that working group. So I'd ask for any considerations along those if people have any thoughts. Fiona.
I think I agree that I think the direction of travel should be this way. I think it's important because with so much effort having gone into trying to amalgamate the CCGs into one Cheshire CCG, it's almost like a sense of relief to have got there. And I do have a feeling of stalling with actually the so what for the population. So I think it's really important that we try and move this forward. However, there's a couple of things that I am anxious about. And while some of you may say that they are not related, I'm speaking as a jobbing GP, looking at these things and thinking they seem very related to me. So there's talk about changing culture in providers. I don't know, and at least two of the slides, I don't know whose responsibility that is. And I think I didn't understand the slide on page 106 about devolving and aligning responsibility, because the arrows all seem to be going in. So it wasn't clear to me who was actually doing the, there's a lot of governance about who should be arranging and allowing work to happen, but then who's actually doing the work, whether that's hospitals, community services, general practice. I didn't understand that slide. So if I don't understand it, then when trying to present this to membership, I don't think they'll understand either. And I genuinely feel uncomfortable about a slide that talks about Cheshire and Merseyside. I don't know anything about Merseyside, and I know that's and I've heard the argument that this is nationally they want us to have that direction of travel, one ICS. I don't think GPs have any notion what an ICS is. I'm not entirely sure that most of our secondary care providers have any notion of what an ICS is either, and I think the two should be kept very far apart, and we should be concentrating on Cheshire, because otherwise we look like that bit's a done deal, and that will only cause aggravation, which will mean that we won't get the buy-in from the people we get the buy-in from, would be my comments.
Fiona,
yeah, before I pass over to Tracy, I'll ask a little bit about the Cheshire and Mersey question. Whenever anybody is talking about any reconfiguration that may or may not happen, and what everybody's very, very clear to say is that place is the most important thing, and that anything else is only there to support place. So actually we're over 2 places, and so we're already in that sort of position. But I think that it is very true that whatever happens around other reconfigurations of any other structures, that actually everybody's in agreement that place is a very, very important level, and that needs to be sort of king in all these considerations. So I'll pass over to Tracy, and then we'll see if we've answered your questions collectively. So Tracy.
Yes, so I'm just checking through the slides. We have a slide that's what is happening outside of Cheshire and Merseyside, so I'm just checking I'm not confusing. So if it's that one you're referring to, it's deliberately about beyond Cheshire and Merseyside is one of the slides.
So just answer that question. So yes, that is the slide I'm referring to. I don't understand why it's not what is going on beyond Cheshire. Here is what's happening in Merseyside as well as Humberside and all the other places. Why is Merseyside even on the title of that slide?
Because we do live within the Cheshire and Merseyside Health and Care Partnerships. I suppose it's just referencing what is happening beyond. It could say what's happening beyond Cheshire. I think it's probably semantics, Fiona, but I understand that might be a little bit sensitive, so I think that's reasonable. The other slide that you mentioned that you said you didn't understand, I'm just wondering if we can pull it up, and then I think Richard probably would like the opportunity to introduce himself and talk that one through. And I'm just trying to find the exact slide number, and then we can do that, Fiona, if that's all right. Bear with. So Noreen, we need to go to slide number. It's slide on 106, I think, is page 106 of the pack that you're referring to, Fiona. So I don't know if we could just put that up, and it talks about
a title for that, because I've got the slide pack. It's obviously numbered differently.
Okay, I don't. It's. Do you want to just put them up? It's about the 4th one from the back of the slide pack. I'll help you find that one. If you could work backwards, please. That's the one. Thank you. Richard, do you want to say a little bit about this to help Fiona's question?
Hi everyone, Richard Burgess, Deputy Director for New Models of Care team. I think what we're trying to articulate with this busy slide, and I appreciate what Fiona's saying, is it could be quite confusing. Often, and historically as well, when we started to talk about developing our ICPs, the focus has always kind of been on what is the CCG doing to develop the ICPs, and what we try to articulate is the system is actually developing the ICP, and the ICPs are also self-developing. What we're talking about functions and services and devolving in, I think the little diagram on the side was really supposed to show about there's levels. I mean, we all know there's multiple levels of bureaucracy in the system that we're trying to remove to create that efficiency. This was trying to articulate that there's elements within each of the providers, acute providers, community providers within the local authorities, and voluntary sector that can all contribute to what an ICP will become, be it aligned, be it actually putting hard resource in there. The way I've always tried to think about this at the moment is, especially working for a long time in kind of performance and contracting, there's an awful lot of duplication within the old system. And the idea is if we look and remove the waste, we can contribute equally resources in from partners to enable the ICPs to start to do what they need to do, the real transformational change. And on the ground, what that means, referring us to the impact to a job in GP. And I think putting in the financial framework along with the staffing framework will really enable them to start to move resources upstream. This is why we've always kind of described this as it's a system investment, as opposed to it's not just the CCG developing another CCG, or I've heard a PCT, you know, or we're just going back to primary care trust days. So I think that was the explanation behind this, and that form is not predetermined. So the bottom point around discussions about staff, we've not determined form, the system hasn't determined form. Those conversations need to take place about alliances, prime providers, or whatever that looks like, and therefore there's many models we can start to investigate to resource ICPs appropriately, aligning our staff, like our primary care development team within the CCG at the moment are working alongside and inside the ICPs. We can second staff temporarily, or we can start to formally move.
Richard, sorry to interject. I'm very mindful of time, and I'd rather be responding to the governing body questions rather than telling them stuff they may or may not already know. But so sorry to cut you off, but I'm just, time is of the essence, and I just want to make sure that we're focusing the discussion on what the governing body need to reach the decision that they need to reach today. So are there further questions from the governing body, or can we focus on that question of the ambition?
So can I just comment then that I think the ambition is good, and I support the ambition, but for the ambition to be realised, the people who it's going to impact on will need to understand what's going on. So while maybe Richard doesn't need to explain it to us, I do think we all maybe need to help you, because I'm still confused how we're explaining it to the other people that we want to understand it, because I don't really, the ambition is great. I think I'm struggling a bit with how it happens. Don't tell me any more now, but I'm just thinking, how do we get that message clear?
Yeah. So I've got Claire and Tracy both putting your hands up.
Yeah. Tracy, go first, if that's okay, Andrew.
That's very helpful, Fiona. So Andy McAlvey is part of that working group, so I'm going to task Andy to help us translate it into a speak that all GPs will love and understand. But as governing body GPs, we need your help with that as well, because when we discuss that with membership, I guess that's why we've got to help us with that. So I'm sure outside of here, Rich and Amanda would spend some time with you getting this into a language that isn't management speak, if that's where it feels like at the moment. So I'll make that commitment to help with that, if that's okay.
And I think, Andrew, Fiona, that's the point of, I guess, it's agreeing today the ambition, supporting the recommendation option 3, hopefully, but then we've said we'll get a working group together, and I think that's the key group. It's both, you know, clinical, it's both sort of governing body, lay member, and it's exec and officer, because we need the whole CCG to be working on this. We need to be able to translate it to partners, but we need to be able to translate it to our staff as well, and to the organisation. And we have a lot to work through. This is just about getting the governing body's support for direction of travel and the ambition. The hard work really starts next in terms of, you know, getting all the details worked up. But, you know, you've got the commitment from the execs, and absolutely from Andrew as well, I think, through the commissioning executive board, that this is part of the next steps in terms of moving the organisation forward. And we're used in the commissioning and contracting intentions, this sort of symbiotic approach. It is about the maturity of the ICPs, but it's also about the maturity of the CCG. It's about letting go and receiving. So we need to work on that together. It's not one doing two, it's about doing it together with the ICPs. But I think today is about getting your support to move that agenda forward at pace.
So I'm going to say that I believe that nobody has spoken against option 3 and has been ambitious about this. So is there anybody who feels that that is the wrong course of action? No. Okay. So then I think that takes us to then the working group. I don't think anybody's going to disagree with the formation of a working group, unless it's Wendy, because the suggestion is that it's under the auspices of the Strategic Commissioning and Performance Committee. So she may object, but I'm assuming that you won't.
I don't object.
So I think we probably then need people to volunteer to sit on that, and of course Claire will nominate people from her teams to be on it. So
yeah. Maybe Andrew, just conscious of time, if people would like to, if that's, unless you want people to nominate themselves now, but I think it's just
no, I was thinking to do this outside the meeting. Yeah.
Maybe if you email me and copy in Tracy, just so we can get those nominations and we can just coordinate that. Thank you.
Okay. And so the other thing for us to do is to support the engagement of both ICP boards to progress this approach, which we've already started, and I'm sure you will agree with, and to progress. We've been asked, and Fiona's point is very well made, to support this with GP membership. I think very helpfully, Fiona's views on how we describe Cheshire and Mersey, I think are helpful pointers. And confirm future reporting arrangement is the last thing we're asked to consider. So I personally would like to see something coming back to the November meeting. So I think that working group hopefully can do some work between now and the November meeting, just 2 months. I think personally I'd like to see more of that outline of what it is that we're going to have in terms of frameworks, both for our relationship with the ICPs, but also about maturity of ICPs and CCGs and strategic CCGs, and that relationship aspect and the ways of working, that we need to have a whole governance framework around this, don't we, to ensure that how we make a robust decision, a series of robust decisions to get to the right place on this one. But I think that will be down to the working group to decide what that needs to be. Should we decide on perhaps the one thing we could do is usually probably decide on a chair of the working group. The obvious person would be to ask Wendy to do it, since it's under the auspices of the Strategic Commissioning and Performance. Would you be content with that, Wendy? Yep. She's nodding. Thank you. Okay.
Yes, I'm happy with this. I've just said I'll volunteer as well.
Thank you.
Thanks.
Lovely. So I think that that concludes that point. If everybody is content, I think that's a major step forward. So thank you very much for your time. Thank you very much, Richard and Amanda, for joining us. And sorry again to cut you off, Richard. So thank you very much. That moves us forward.
Thank you.
To item 4.4, which is the phase 3 response to the NHS response to COVID-19, which Claire is going to lead on for us.
Noreen, could you put the presentation up, please? Now, I'm really conscious of time, so I will go through this as quickly as possible, and I will assume that you've read it, and I'll assume that you'll ask questions at the end. Okay, so next slide, please. Thank you. So what I want you to talk about is key developments, priorities going forward, and what role the governing body wants to play in leading the phase 3 response. Next slide, please. You can see we've come through the peak of coronavirus, or so we hope. Let's see what happens over the coming weeks and months, but we have to remain vigilant. And I'm sure if Ian were here, and hopefully he will be, I'm going to text him halfway through this presentation, or somebody else can text him, please, to sort of say where we're up to. We have to remain vigilant, and we've got our plans in place to do that. Thank you. You can see the key documents and key developments. So we've got the people plan, phase 3 letter, and the phase 3 implementation guidance. They were all published in the summer. This presentation sets out the CCG requirements akin to those. Thank you. So from a regional perspective, we are still in command control, although the national pandemic has been moved down to level 3. But increasingly, some of the influence is moving to being devolved incrementally to the healthcare partnership level, but the hospital and out of hospital cells still remain. And importantly, particularly in light of my new role as inequalities lead for the governing body, the North West Community Risk Reduction Framework has been published, and that's a really good document that we need to use as part of our commissioning. Next slide, please. This just sets out how the region, the North West region, is managing its work and its agenda over the coming couple of years, really in terms of restore, prepare and transform. So I think that's helpful. So we will be working with the regional team where appropriate on our plans to move forward. Next slide, please. So key priorities around restoration, the return of non-COVID related services, winter and COVID demand, and doing things differently. You can see there a list of sort of summary list of what we need to do in terms of the elective activity, cancer, restoring community mental health services and primary care, as well as managing winter, all the PPE, IPC measures, and working with our public health colleagues around that. Next slide, please. Right, I'm not going to go through these, but you can see on the left, you've got the national requirements in terms of increasing activity incrementally, but the ambition will be for some areas, we have to be trying to do over 100% of where we were last year to make up for the sort of the reduced activity during COVID, because we know referrals were down. We know that all parts of the health and care sector couldn't do the traditional sort of planned activity because the focus was on COVID. So on these next few slides, you've got the national requirements to the left, the challenges to the right, and some of the opportunities. So happy and/or colleagues can answer questions on these, but I think it's important to see what we are required as a system. And this is at Cheshire, because we are working as Cheshire very close with all of our four key providers, NHS providers on this. So to keep going, please, Noreen, to maybe that's right, thank you. So we've already talked about today the letter, Andrew mentioned it at the beginning in terms of the letter around access to general practice that went out, which was not particularly well received, because we know that primary care has been open for business, as has the NHS throughout the COVID pandemic. The model of delivery has been different in some cases. There has been remote consulting. We have used technology differently, and we've looked at a new creative way of doing things. But the NHS and primary care is open for business, and you can see there a whole list of what practices are doing to reintroduce services, to re-establish themselves. Same with, it's okay, Noreen, you can keep going. Same with community services, how we're working jointly with our local authority colleagues, how we're working with mental health, how we're looking at integrated discharge, and obviously the most vulnerable patients will always be the priority. Thank you. You can see there some more restoration around CHC. We have a backlog of, I think, something like 800 patients who are both COVID, non-COVID related, because we were asked nationally to stop CHC assessments during the heart of the pandemic. These have been reintroduced from the beginning of September, and the CHC team at the CCG are doing an excellent job at managing that through. You can see there in terms of acute services, reintroduction of services. Okay, thank you. So there's all the reintroduction of services, but there's also planning for the future, and phase 3 planning takes us to the end of the financial year. So all systems, so as I said, we are working as Cheshire, so the CCG working with the four NHS providers, but working closely with local authority colleagues, general practice, working at all of our plans in terms of restoring activity, preparing for winter, and making sure that we try and provide the best possible service for our patients. Next slide, please, Noreen. Thank you. So Linda, you can probably contribute here, please, but here is the financial summary and assumptions, is that we will retain our block contracts, our mental health investment standards funding will be met. We have a process around COVID funding. Yesterday we received the new guidance for months 7 to 12 financial planning. I think there are workshops and phone calls literally as we speak. So Alex and Katie are on those. So Linda and her team will be producing a sort of a summary to share with the governing body on the new guidance to help us understand sort of the flow of finances until the end of the financial year. Thank you. As I've sort of referred to earlier, we have a single winter plan across Cheshire. It's the first time we've done that. I think it's the right thing to do in terms of the way we're working as a system, in terms of mutual aid, in terms of peer accountability, and in terms of supporting the wider system. And that does include out of hospital and hospital cells across Cheshire and Mersey. To support that, we've made the decision to have a single A&E delivery board. We've been talking about this for some time. I think now is the right time to hold each other to account in that forum, and all of the providers are supportive of that. Cancer plans, as I said before, we know this is a concern across Cheshire and Mersey, but it is a concern with our providers, particularly around waiting lists and diagnostics. So we are working closely with our providers, and Sinead has offered her services to sort of take a clinical lead on that. So thank you, Sinead. Next slide, please. Referenced earlier, the NHS plan. We're going to be bringing more information back next month on that, but this is very much about supporting staff, not just through COVID. Obviously, we need to focus on people's well-being and all the enormous work and the fantastic work that the NHS staff have been doing. But this is a wider document in terms of supporting workforce in the future for the NHS, but we'll bring something back next month. Thank you. Again, addressing inequalities, this is part of the phase 3 planning. You've got the 8 urgent actions there, and what we will do as part of myself with Mike and the 2 directors of public health, we'll bring something back next month or the month after to outline our plan towards delivering these for the population of Cheshire and the CCG. Thank you. And you can see there, nothing about us without us. And I saw that quote in the chat at a meeting earlier on with the healthcare partnership, and I think that's really important, both in terms of the population, the staff that we're working for. We need to make sure that we engage, and I think it's hopefully relatively seamless in terms of the agenda item on engagement and communication strategy later. Everything that we do as a CCG, we need to engage and work with our population. Thank you. So I appreciate that was a very, very quick canter through some incredibly important national and regional documents in terms of phase 3 planning, in terms of the people plan and the implementation. But I think it was just to assure the governing body that this is part of our absolute everyday work. There's an enormous amount of work going on in terms of planning, working with our providers to submit the plans, and we are meeting the deadlines. We've met all the deadlines around winter. We've got the sort of final versions going in as we speak. We're working as part of the healthcare partnership population. So when we talk about system responses, it isn't just Cheshire, it's Cheshire as part of Cheshire and Mersey. But we're meeting our requirements around that, and we're going to learn lessons, because obviously the phase 3 planning takes us to the end of the financial year. We'll then have to probably post Christmas in the last 3 months of the new calendar year, but have to start planning for 21-22. And I think what we want to do is learn lessons from what we've had to do over the past few weeks, and the time frame has been incredibly tight. So everyone's worked really, really hard and worked really well together. So using the phase 3 planning to restore services for the population in anticipation of winter, and recognising that COVID hasn't gone away. So I just wanted to leave it there, Andrew, if that's okay. I guess it's about how the governing body want to seek assurance but also what role the governing body wants to play.
Thank you very much.
Thank you.
I'll take comments and questions. Just check. I haven't checked my little chat box. Okay. So nothing in the little chat box. Could you say, Claire, at the moment, where is this being reported to through the committee structure, if at all? What's the present governance we have?
The financial planning was. Oh, can you hear me still?
Yep.
Yeah, sorry. Financial planning will be through Finance Committee. Winter plan is through the Strategic Commissioning and Performance Committee. I mean, the details of the plans are, you know, their numbers, their activity. So if I'm honest, I don't think we had planned to share the absolute, excuse me, that's my telephone, share the detail of all the figures and numbers in terms of activity. I think the narrative, the plans we can share through the Strategic Commissioning and Performance.
Okay, thank you.
Okay.
Any further? Okay, Mike, Mike, and then Suzanne.
Thanks. So just a quick question. I'm just trying to work it out in my head. So as we evolve with COVID again, how are we going to prioritise the return of non-COVID services, winter, COVID? What's going to take priority? And I guess the answer is it depends how severe COVID is. But take smears or mammograms for an example. And we want to try and get those cancer services, screening services back up and running. But winter pressures may be taking staff away. COVID may be making it high risk for patients to be on sites that provide those screening services. How are we going to balance that? How are we going to work out the priorities? I don't think you've got a simple answer because it's going to be complex, but do we have a plan how all those bits of the system work together?
Well, we do, I think, through, and maybe Andy and Sinead might want to come in here, please. I mean, the key challenge is to restore as many services as possible, as quickly as possible, in anticipation of winter. And I think I'm sure Ian's here to talk about, you know, where we are in the Northwest and beyond with COVID. So we're trying to do that, but ultimately we have to restore services safely for the patients and safely for the staff. So ultimately, patient safety will trump anything, I think. So we'll restore services as quickly as possible. If we have to cancel activity because of COVID, we'll do the right thing. I mean, normally over winter, as you know, we cancel electives. The plan hadn't been to cancel electives over the winter as part of the restoration and the activity plans and the winter plans. But we will just have to go with both national guidance on what we as a Cheshire feel safe. I think, you know, medical directors are meeting, the chief execs are meeting. So those are the conversations that we have, you know, advised by Public Health England and by our directors of public health.
Thank you. I think Dr. McKelvey's indicated that he might be able to add to that question.
Okay,
thank you, Chair. Andy McKelvey, I'm one of the Associate Clinical Directors at the CCG. I think Claire has responded as well as I could really, even from my clinical background. Mike, to reassure you, I think we've got the COVID pandemic, but what we've seen from the pandemic so far is when we've cancelled everything to respond to it, and we've done that heroically, sadly, some of the other services outside infectious illness have deteriorated. So we've got to actually maintain as much as we can the expertise, certainly in those places where you need it. So, for example, in general practice, I'd like to see experienced general practitioners work on non-COVID work, which is extremely complex. All the cancer work, all the IHD work, all the long-term condition management, all the screening programs to actually maintain that care that patients need. The infectious illness and the COVID stuff, we need to actually think within our health system, what's the best place and how to resource that and how to staff it. And keep that, if we can let both work together almost in parallel, if you like. That said, we've got a finite workforce. we've got finite capacity, we've got finite resources, and when it comes to capacity and space, we need to be imaginative in how we actually deliver those services, and we've got to try and do that, you know, within a cost base that's reasonable too. So they're the things that we're balancing, but we're looking at the right, you know, it's almost like letting the providers, both in primary care, community care, secondary care, and this has been a real way of flexing some of the skills within our ICPs to actually respond to that. And so far, it's been really encouraging.
Thank you very much, Andy. It's helpful to know, and I think very important points that you make, because there are no safe options here. They're all, you've got to balance the risks one way or the other, haven't you, between dealing with infectious COVID disease and dealing with the routine work, all of which has a purpose. Otherwise, we wouldn't have been doing it in the first place. So yeah, it's a difficult balance. Thank you. So Suzanne, you were going to comment.
Sorry, I'm muting. It was just in response to the role of the governing body. I thought this was a really useful presentation, sort of bringing all the things that came out over the summer in relation to phase 3. I think a lot of the stuff will go down into the subcommittees, whether it's finance, winter plans, etc. And I think we'll all be seeing it there. I think my thoughts were into what does the governing body want to see is probably things coming up by exception. So the things that perhaps aren't going right, or there's a particular issue, or even the success stories would be good to hear as well, to be honest. But I think that sort of thing is probably what we need to hear as a governing body, and assuming that the rest of it we will see in the various committees. That would be my thoughts.
No, that's helpful, Suzanne. Thank you. Because obviously, what I try and do in the AO report is report on things that don't sit elsewhere. So I can either bring it, you know, a very small sort of assurance in terms of progress overall through that report, or as you say, good practice, best practice. So we can do that through the AO report probably for the next couple of months. Thank you.
Thank you very much. I don't seem to have any further questions or comments. So I think we are asked in that to note the contents of the presentation, which we have done. Confirm our expectations with regard to future reporting requirements, which we've just discussed, and consider and determine how the governing body wish to lead this work going forward. I think we've discussed how it is already part of the committee structures in terms of the planning and exceptional reporting into the governing body. So if there's no more to add on that, am I taking that we are content with those items? Thank you.
Thank you.
And I can thank you very much. I can say that very happily we've been joined by Ian Ashworth, who will ask Ian to introduce himself any second now, because our next item is the public health update for Cheshire West and Chester, item 4.5. So Ian, do you want to, sorry, just before you do kick off, I think the second part is the government obesity strategy, and I think this is an opportunity for us to do some joint working and some synergy between what we're doing in health and what's happening, or have been happening jointly, led by public health in an activity that's already been going on. So perhaps you can tell us about both those things. So Ian.
Thank you, Chair. Good afternoon, everybody. Sorry, I've joined you a little bit late. So I'm Ian Ashworth, Director of Public Health here at Cheshire West and Chester. I'm very conscious you've had some very meaty agendas and been having fantastic debate on some of them. So we're a little bit behind schedule. So please, if you can buckle yourself in, I will go through this quite rapidly. The presentation slides are there to refer to, and hopefully members of the public can also get access to them on the website as well. And I think things have changed a little bit. The idea was to just give you a response on what we've done in public health as part of the COVID response, particularly from a local authority perspective. And although it's focused on Cheshire West and Chester, my colleagues in Cheshire East, we work really closely together, and it's very similar as well. So I think Noreen's going to fly us through this. I'll just give you an oversight of where we're up to now, touch on some of the responses that we do, and then maybe we'll have a couple of minutes at the end to touch base. We'll then move on to the obesity strategy, which again, there's recommendations in the paper. You've seen that. We won't have too much debate on that, but there's real good opportunity to do things jointly there. So unfortunately, we've seen a pretty significant increase in the cases of COVID in the last couple of weeks. And I say that as a system for Cheshire and Merseyside, really. Our friends, our loved ones, our family all work and travel and go around the sub-region. So we keep a watchful eye on that. The virus doesn't stop at the end of the street, which we all know. So our teams really closely look at all the different borders coming into Cheshire. That might be North Wales, it might be Wirral, it might be Shropshire, it might be Manchester, Warrington, etc. So we keep an eye on that. Sadly for Cheshire West and Chester, and similar to Cheshire East, I have to say, in August for Cheshire West and Chester, we had about 108 cases that happened of COVID confirmed. We're halfway through September with some incomplete information. That's already 168 cases. So you can see the rise just in the absolute figures there. The rates themselves have trebled since August. So my tone, you'll have to excuse me. Well, you know, it's really quite important and stark that we could take note of this. And it's very well documented what's happening in our areas in Warrington and Merseyside. And particularly what's been quite scary is to see the increase in rate, I think, in Warrington in a matter of a week. And so no one's immune to any of us, quite clearly. But we're seeing our rates increase as our Cheshire East colleagues, and particularly our colleagues and neighbours in Merseyside and other parts of Cheshire and Warrington as well. So our rates are around about been fluctuating in the last week or so up to this sort of 30 per 100,000 per week. So to give you that some stark, a lot of the areas that you might have seen on the watch list recently, on a national watch list, are touching on and over now 100. So you can see where we've come from, and then the travelling of those rates is pretty, you know, serious, and well dealt. We're obviously heading into a second wave, but we're not at the same levels as our neighbours, and I suppose that's important to know. So, your Director of Public Health work together collectively. We have a very strong footing with the Cheshire and Merseyside for the reasons I've just outlined, and we try to have consistent approaches wherever we can to get that sort of to avoid confusion and make sure that we have measures in place that don't that actually are consistent and don't change based on the different roads you travel on and things like that. So we're working closely together and have been throughout. So that's where we are currently. I think this presentation tells you about the response that we've done so far, gives you a bit of a concept of what we've done, and but I'm going to cut a few bits out if that's okay, and we can take some questions. Slides in front of everybody just gives you an insight into the world of the local resilience forum and how we report into the Cabinet Office nationally through the Ministry of Housing, Communities and Local Government. Cheshire has a local resilience forum, and that is where all our colleagues from NHS England and police, fire, utilities, the local authorities all come together for any type of emergency issue, and they can sometimes be stood up. And that's like what might be termed your goal command or strategic command group. Underneath that, you have the tactical group, which is the silver command as well. And there's obviously a national sort of chairs group of LRFs, and that's how our response has been done and managed. So we've been playing parts of that with multiple cells. The CCG obviously has its part within the command and control function and plays its part within this, which is part of the NHS as well. So it's worthwhile just highlighting some of that work and how your local authorities in Holton, Warrington, Cheshire East and Cheshire West work collectively together on major issues. If you could go to the next slide, please. Wow, so that's a small writing on the bottom, but this is the internal sort of setup we put in our organisation. We have a goal command at the top, which is chaired by our Chief Executive, Corporate Leadership Team, and Andrew Lewis. I chair something called CMART. It's a fancy acronym, isn't it? So that's the Council's Emergency Management and Response Team, and that was stood up early in February that I coordinated, and we stood up a range of different cells led mainly by directors within the council and done jointly with our colleagues in the NHS as well. You'll see the variety of cells that evolved over the time, and which we'll touch on in the presentation. Essentially, our response has been slimmed down, shall we say, because of the the nature of it, and then we always constantly review what cells we may or may not need to stand up and moving forward. So the test and trace cell at the beginning in February wasn't a cell that we wouldn't need to do, but now it's more fundamental than ever. If we can move on, please. Okay. There's a number of these slides in the pack, and what I want to just try and echo is I did a similar presentation to our clinical forensic accountants at Cheshire in one of their ground rounds. It's just showed the work that's done through the local authority and the community sector jointly with the NHS, and that other side of how we've been supporting the shielded population, of which I believe hopefully there's some text messages and information going out through our GP systems today, making people aware of these rising infection rates as well, and to be more vigilant and COVID conscious when they're out and about as well. So perfect example of how we all work together. The food parcels on there quite significant in the bottom left hand corner, the ones that have been arranged to go out. I have to say we were ready as a system locally, ready to support that with the support from our colleagues in general practice. The challenge was getting the right information through and details through to us to be able to act on that in a timely way. And the team working together in business intelligence and our team in the council have been superb in helping that make sure that our shielded population, our vulnerable population, get that support where they need. You also see on the right hand side of that slide the community response. So one of the first things I had asked one of our colleagues to do was work with the local voluntary community sector in Cheshire West Voluntary Action. We recognise we are very fortunate to have such willing volunteers and such willing members of the public who want to help others at a time of crisis. And you can see the numbers there that joined the cause. Obviously, that's complemented by the NHS volunteering scheme and how we've been able to deploy them at the right needs as well. So if you could just move on. I'm conscious I've already promised I'd do longer than I would do, wouldn't I? So one of the issues we face with personal protective equipment, I think this is probably well documented. We have had a number of pandemic scrutinies already, which has been great to put our joint approach and lessons learned from all of that. We had our own personal protective equipment cell. We had those challenges where there's different guidance coming out on a daily basis sometimes, and which sometimes put us at put our workers who are working with the same residents, the same patients with different guidance, and that just wasn't quite right. So I'm hoping that sort of saturation of guidance on PPE might be settled down now, but it's been that was one of the significant challenges that we put together, but we work well together, and I think I'm glad I saw one of your CCG colleagues on here before on a previous who was helping out with the council to manage that cell. So thank you to that. If we go next slide. You've talked about integrated care program before. I think it was just to recognise, and we established a care home cell jointly across Cheshire East, Cheshire West, and with the CCG. We've recently sort of wound that down. Colleagues in Paula's team and Jamila were instrumental in helping us make sure that we had a single approach to supporting our care homes and understand the implications in adult social care and the interface with the NHS. Again, if we need to stand that back up, that's highly recommended as we go through that. You also looked at homelessness as well. At the beginning of the pandemic, we identified through a range of different exercises this is going to be a really significant time, and it shows you the numbers of people we were able to house in local sort of hostels and groups around that moving forward, because actually we do know that COVID has increased inequalities and impacts the most vulnerable in the worst possible way. Next slide, please, sorry. Told you need to buckle in a bit. We had children's information on here is really, really important. Thankfully, our schools and education are doing wonderful jobs in getting people back in a very challenging situation and time. We also know that sadly, not every child has a safe home or in an area that when they're not in school, and we've seen that, and we saw an increase in the number of referrals of children in need as well to support for our teams. And I think that's something that's always in the back of our minds when those self-isolation things happen and they're not in school in a safe environment, and we always need to think about those inequalities in there as well. We also saw, and from other areas, increases in domestic abuse referrals, and that's something that you can actually see and you follow on the chart on the bottom right as well. Okay, I'm going to the next slide. I'm going to cut a few things out, but one clear thing for me is the importance of partnership work, and we've heard it on many times, but a lot of it comes down to also building the rapport, the trust, and with individual relationships, particularly on the governing body. So thank you to that. And making sure that we're all under very pressured areas and we all want the same things, but trying to get that collective message out, trying to make sure that we're all going in the same direction and providing challenge when we think it's right. It's so important, and I think we are really fortunate to have those relationships in place, and something we should be commended for. Not easy to do all that, and it takes a lot of time and effort. So, and we'll all occasionally get a few things wrong, but it's well worth noticing, and it just captures what a system we work in when we have to go around that. No particular order, obviously, on that slide, but there we go. I'm going to jump a few slides forward now, if that's okay. And I'm going to just move us to slide 13, I think it is, called Test and Trace, if that's okay. So on a previous governing body, I referenced that Cheshire West and Chester was a Beacon Council nominated for being one of the top 11 areas to hopefully develop outbreak management plans. We're still influencing the national agenda around that, lessons learned, trying to share good practice as well about how we prevent the spread of coronavirus. We were identified to try and establish a plan that had 7 key themes, which I've shared with you before on there, and they still exist around care homes, developing a local testing plan. We've been doing that collectively together, some of things outside of our gift quite clearly, but we continue to do that to make sure we can plan and get, we made a number of requests to get access to our residents for future testing facilities. Clearly, there's a lot of challenges going on at the moment as well. If we can move on to the next one on local contact tracing, we're starting to step up a range of different things related to the national test and trace programme that was introduced. The Directors of Public Health for Cheshire East and Cheshire West work with our Medside colleagues and the local Health Protection Public Health England team. We established their own hub where contact tracers and local professionals from the area are coming together and dealing with complex cases. Now, what we are now being asked to do from local areas is where there's been loss to follow up from the National Contact Tracing Centre, and they're asking local authorities if they can do that exercise themselves without any additional resource. We will do everything we can to make sure that we follow those cases up where we can. So we're trying to explore pilot and some of that as well ourselves. I think it's fair to say one of the things we found out is that we find out about cases or issues in local neighbourhoods, businesses, hospitality, way before the national team notify us. And that's one of the reasons why doing these things locally is really valuable. So we've got local intel from yourselves as well, and the GPs that we'll continue to act on. If you can go to the next slide, please. The fundamental focus is not about outbreak management per se, it's been about prevention for us. And a lot of our efforts have been placed on working with regulatory services, environmental health to make sure our venues are COVID secure. We've done, you can see some of the figures on there that we've been trying to do that. There's also making sure that, you know, our residents are paying money and going into places, they should be expecting the highest of quality and be able to enjoy that in a safe and secure way. Businesses are going to great expense to do this, and now we're at the stage where actually, you know, everybody needs to have these high standards if we're going to continue to enjoy the hospitality and protect our jobs and our livelihoods and our sector with all of that. So you'll see where I'm coming to in a moment. If you can move on, please, to enforcement and powers. Thank you, Noreen. So you may have heard something called the Contain framework. There's a new set of laws and powers that have come through that encourages, that supports local areas to act on areas where there's a threat to public health through coronavirus. And these allow us to either close premises, outdoor places, restrict events, and limit powers to refrain from people who present a threat to the public. So that might be a business who isn't adhering to COVID secure measures, who needs directions on that. It might be a number of gatherings, etc. So we can do something about that now and hopefully challenge where we think it's right to challenge. And I'm of the opinion, you know, ignorance is not an excuse at all with any of this, and we need to all be playing our part. So moving on to something a little bit more proactive, we had a little bit of a discussion at Health and Wellbeing Board yesterday. We have launched a Community Champions programme, which is done jointly with all our partners. This is just about building on the 2,000 volunteers we said at the beginning of the presentation, how we can get direct messages out into each local areas. There's a couple of videos we put out through there. One of your clinical colleagues, Dr. Chris Richardson, has done a little video to aid very much our parents and schools about making sure that the only people who are getting the symptoms associated with COVID go and get a test and things like that. I think there's been a lot of demand being faced in primary care and phone calls around worries about symptoms not associated with that, which was always going to be the way when schools went back as well. So when you get a chance, please sign up to that and look into it as well. And if we can just quickly move on, final slide, challenges, issues and opportunities. So I might have not been my usual chipper self. I think it's really important that you see that the rate of increases is very real. And I'm sure, sadly, if we look back, we know that the increases in infection will sadly lead to increases in admissions. There might be better ways to treat, but that will sadly then lead to long-term conditions and and deaths. So now's the time for us to make sure that we reinforce those messages around your hand, face and space, making sure we get the social distancing right, COVID secure measures in place, making sure that people are all sticking to the rules as best as possible, really. But making sure we also learned about the lessons we learned from the first time around. Some of the things are featured within this report. So I'm going to stop there because I obviously went over a little bit. So I'd welcome any questions or comments at all.
So thank you very much, Ian. I'm afraid I'm going to be brutal and restrict your questioning to questions which are important assurance questions, if we could please, because unfortunately we are now an hour behind on our schedule. So very interesting presentation. Thank you very much, Ian. Are there any questions for Ian? I'm sure that Ian would be delighted to discuss that outside of the meeting, because I'm convinced that governing body members are interested and do want to ask questions, but my restrictions probably inhibited some of them.
Chair, that's quite all right, and I quite understand. I had enough airtime as it was. That's fine. So any questions afterwards, more than welcome. Please come to us.
Lovely. Thank you very much, Ian. And we've also got you for the government obesity strategy.
Yes. So look, how do you follow that? So in the papers, you have an update, and this was about basically reinforcing some of the things we're doing already in Cheshire West and Chester that the CCG have been part of prior to becoming Cheshire CCG as well, and developing new pathways and everything. And during the summer months was the launch of the new obesity strategy. I'm not going to go into the detail of the paper. You've got that there. There's a number of recommendations within that, and essentially it's about us trying to, I think you don't need me to explain why the benefits of doing that, especially over COVID and getting us physically active. I need to get off this seat myself a lot more, sadly. So, but there's a number of things in there that we can build upon locally, and they're the type of things that we should be trying to hopefully enhance. And as more comes aware of the national strategy, whether that be the diabetes prevention program that has been developed, it's those type of things that we should have a joined up approach about for our residents. So you see a number of recommendations in there. I think we have signed up as a local authority to the Healthy Weight Declaration. Without stealing anyone's funds, I do know the Clinical Commissioning Group, the Integrated Care Partnership, and Cheshire and Will Partnership Foundation Trust are all keen to do that. It would be great to have it all be done at the same time with the NHS around signing up to that pledge, really. I'm going to pause there, just conscious of time, really. That doesn't mean it's not a big issue, but I'd more of rather any comments or questions on it if there's any issues with the recommendations, Chair.
Thank you very much, Ian, and my apologies that we've squeezed things a little bit. As you rightly say, extremely important issue, as of course was your last presentation, extraordinarily interesting. I've got three people, so I've got Paula. I'm not clear, Paula, whether I missed that from the first of Ian's presentation or whether it's on the second. So Paula, please.
Yeah, sorry, Chair. It was to do with the first presentation. It was really just to thank him for that presentation and thank him for his leadership on this. I've been in lots of the meetings and groups where Ian's been leading us through this, and I have to say that there isn't a lot of experience of getting through something at this scale and pace previously. So I just want to say thank you on behalf of the governing body for that, Ian. And then second point really was to say, you've made a point about learning from previous experience. It's not obviously to be done now, we're really tight for time, but I'm really keen that if we need to have conversations offline about stuff that we did previously, either well or need to do better, I'm really keen to be up to my neck in those conversations, please, Ian.
That'd be great. Thank you, Paula. We can follow up on that one, definitely.
Thank you, Paula. So, and then I think the next two people want to come, I think, are on your second item. So Tracy and then, sorry, Peter, Tracy, and then Claire. No one's given their tea tonight.
Is it me first or Tracy? Do you want to go
sorry,
first?
Peter, you're first. You're first.
Thank you. What I'm really after is sort of finessing the recommendations a little bit in the light of some of our previous conversations. First of all, in the interest of equity and equality, what we do for the West, we've got to do for the East. And either we're expecting a similar paper from Cheshire East, or we try to adapt what we have here for for the whole of Cheshire. Secondly, thinking about ICPs and care communities, this seems to me something which an ICP could and should be accountable for, and we should set our recommendations accordingly. Simply because an ICP should be accountable for this, simply because it's best delivered, I believe, at care community level. And we haven't got reference to the ICP or the care community within those recommendations, and I think we should have.
Chairs, am I okay to come back on that?
Yeah, please come back in. Yes, please come back.
I'm used to Teams. I need to work out my button to put my hand up. Thank you very much, Peter. I absolutely hear you. Unfortunately, Cheshire East couldn't be here today. I think initially the idea was let's have that commissioning type discussion now, because the national strategy's come out. Let's have that conversation, get it on the agenda, thrash this out, which is great. There's also, I mean, let's be honest, sometimes things come out nationally that land with a thud, and you've got to act on it. So this is about trying to have a proactive discussion about it. And yes, by all means, it's if the ICP is the way that the CCG would like to see some of these things delivered, then that the delivery mechanism isn't of an issue with us. It's about trying to make sure that's local and we join things up. Sometimes there's been challenges in the past when a national programme can land and it doesn't tie in with the local element. And we've had discussions here in the past where sadly I've had to restrict some of the stop smoking services and things like that. And it's like, well, how can we get the greatest joint investment for the services that we can pile together? So more than happy to talk about that. I think the principles were probably the same for Cheshire West and Cheshire East. It's just the delivery type mechanisms, and it's also just let's see what comes out from the national strategy a little bit more that comes from that. I'm just going to lead hopefully to Tracy, because I do know Tracy's been actively involved in some of those discussions. So Chair, if I may pass to Tracy, if that's okay.
Yeah, Tracy's also got a question, I think, so, or a comment.
Yeah, that links in seamlessly. I just wanted to confirm that I've had the conversations, as you mentioned, Ian, with Lydia Orford and Councillor Louise Gittins around this agenda, and then making sure that we've got clinical input as well as officer input into the group, which I think has been present in the past from West Cheshire CCG, but now we need to make sure that from Cheshire CCG that's in, and that we're available to do that and supporting it. I also then had the conversation about, should this be something that we're looking at on an LRF footprint, so not because actually how do we do that on a bigger scale? And I think that I want to leave that thought there, but I think that this is something that would merit looking at how all our collective public sector resources come together to get behind. So I think that was just a comment. My question, and I'll just leave as a comment rather than you answering it in the interest of time, is to give my support for the recommendations, but just the question would relate to under the recommendations, the third bullet point from the bottom, Ian, and it says about building capacity at a local level with existing primary care staff. I'd just like to make the comment that I think it should be all health and care staff, not just primary care staff. I would see social workers, occupational health therapists, you name it, everybody taking a role in this, not just those that are in primary care. So I'd just like to wonder if we should amend that. It's about everybody, and voluntary sector, third sector, everybody that touches, you know, in terms of contact with somebody could have an input on this agenda. And I think we should recognise it's not just primary care staff, if that's okay.
Thank you. Thank you very much. I think Claire, you wanted to come in.
So thank you. So firstly, I think it's a little bit like Paula to thank Ian for his leadership over the past 6 months, it seems like, and I guess to reassure Peter that you know, we have the same conversations with Cheshire East Council as we do with Cheshire West and Chester. It's just availability of the Director of Public Health to be here today. That was a clear ask from the CCG, obviously both Ian and Matt are members of the governing body, so ideally it would have been a double act, but obviously it couldn't be. So thank you, Ian, for everything you've been doing. And I have to say, Paula says, you know, absolutely brilliant in terms of commitment and leadership over the past few months. I won't say anything else in terms of the obesity. Every contact counts. I think it's everybody very much supportive of Ian in terms of, if we've got something running locally, let's retrofit it into sort of a national heading, but let's keep our local initiatives rather than stop something we've been doing and then recreate it under a national banner. We know what the challenge is around obesity, so I think it's about doing this in partnership, and we've already made that commitment separately, so that's great. Thank you.
Okay, thank you. I've got further people on, and what I really, if you're going to repeat something that somebody else has said, please, can we not do that? So we've Mike, and then I'll read out a comment from Chris.
It's a very quick one. I won't repeat anything, but just for definition, a little bit uncomfortable with the recommendation, the second to last one, natural health services. That could be interpreted in lots of ways. I think it does have a clear definition for yourselves in Mercia and parts of Cheshire. But the way I read that to start with could be lots of holistic, out of mainstream medicine connotations. So again, just a definition that goes with that is what you mean by natural health services.
So good point, Mike. So the natural health service is actually something we're very proud of. It's won a public health awards. It's innovative. It's been led through the Mersey Forest, and very much is about getting referrals and mindfulness out into the community and forestry schools and everything that goes with that. I would actually like to say if it's okay, Chair, maybe I can send a bit of a link to governing body members of what that service is. It's something that we're really keen to develop and feeds into the climate change agenda and everything like that. I can understand the confusion if you're not familiar with that. That's a good point, and I understand. So I'll send a link around afterwards, and maybe put the reference into what is the natural health service in the paper.
Thank you.
Thanks, Ian.
Very welcome. Thank you. And I will just read out a comment from Chris Lynch, which is a reflection on language about using the term, firstly, healthy weight management rather than obesity as a strategy. So.
Yeah, so we caught, I agree, Chris, yeah. So our strategy is the Eat Well Be Active strategy. I think the national strategy is, it's nationally set. So we'll call it what we want locally, is my view.
Yeah, brilliant. So that's
right, sorry.
Yeah, that's the national wording. We will do something different. Brilliant.
We are.
Good answer. Yeah. We are doing something different. Brilliant. So there are for that second item, there are on page 132 and over onto page 133, a number of recommendations the governing body is asked to consider, and I think people have read those, and I think following the discussions, we're happy to accept those, unless I have anybody say anything different in the next few seconds. Lovely. Thank you very much, and thank you for both of those presentations, Ian They were both very informative, and I'm sorry to have squeezed them a little bit and probably not given them the time that they should really have had.
Thank you, Chair. Colleagues.
Thank you very much. Right, I'm looking at the time that we have and what we need to achieve, and I'm going to suggest that we look to defer some of this and perhaps consider having an October governing body, because I think otherwise we are not going. We've got a part 2 meeting to have after this, so which is already scheduled to go on into the early evening. So I think sensibly we should defer things rather than rush them. So I'm going to suggest that we defer the engagement and communication strategy. It's an important piece of work. It's a good piece of work, and I'd rather that we defer it a month and give it the time that it should have, rather than we rush through it now. Is that acceptable to governing body members? Lovely, thank you very much. So apologies to Jonathan, Katie and Matthew, who are probably ready to present that, but let's defer that and then look at our assurance items. And what I'm going to ask for these is, please, those who are presenting can focus on points of escalation to the governing body and decisions required of the governing body, and that we as the governing body members and perhaps restrict our interactions to points of assurance around these reports. This is a new that we've done these reports. I actually, when reading them, found them extraordinarily helpful, being more focused. I found it very, I got more from them than perhaps sometimes I have some of the longer reports. It's a way of working that I'm sure we will need to continue to progress. It's not my intention that we just sort of wash over this section, even though today we are particularly, unfortunately, short of time. So if we can start, please, with the finance paper, and I'm handing over to Suzanne for this initially, I believe. Suzanne.
Yeah, thank you, Chair. I'm just going to turn to the page 169 in the interest of being brief. I think there's just 2 points there. One is about the Midlands CSU contract, which we approved the direction of travel. And the other point is just to say we reviewed and agreed the revised procurement policy. I think I'll assume everything else has been read, so unless there's any questions, I shall pass over to Linda to do the finance report.
Thank you, Linda.
Thank you.
Hi there. So in the interest of time, I'm going to assume that you've read all of this. I will be very brief in what I am going to say, so I will take only the high level things that we've got. In terms of the allocation, we'll all be aware that we've had a budget that's been set higher than the allocation, but we still have a deficit. So in summary, the financial position towards the end of July is that we have a £5.8 million deficit. We have received £6 million more in the budget to fund the services that we're currently purchasing. We have then received an additional 12 million at the end of the month, and we have incurred an additional 10.5 million pounds worth of COVID costs. So effectively, we're running at a 5.8 million pounds of deficit, but after receiving an additional 18 million pounds worth of income and incurring an additional 10.5 million pounds worth of COVID costs. We are running at, okay.
Can we have the presentation up, please?
Okay. So I'm going to have to do it because otherwise it's just going to get really confusing for people. So if we start at the beginning, can I have slide 1, please? So I'm going to start with some context. So we were given an allocation at the beginning of the year, and that was suspended. And we had a nationally set budget, which was based on our previous year expenditure. So the budget we've got is £1.5 million a month higher. Yeah. And then we are getting also money at the end of the month to cover our deficit. So we have effectively got a £5.8 million deficit at the moment, but we've received an additional £18 million worth of allocation, and we've incurred an additional £10.5 million worth of COVID costs. So that's why we've got 5.8 million deficit. The other thing to mention is that whilst the overall budget is higher, the running cost is set below allocation because it was set on the 1920 costs, and we were intentionally carrying a lot of vacancies pre-merger. So the running cost budget we've been set is actually lower than our expenditure because we set a budget based on the allocation, not the budget. So we are missing our running cost target is the bottom line, and we're discussing this with NHSE. We've agreed that this will be discussed once the new guidance is out, so we'll be talking to them about that early next week. If we move on to the second slide, this is a high-level explanation of those areas where we've got a significant overspend on the budget. I won't go through each one individually, I'm sure you can read it, but the underlying issue is that the budget that we've been given doesn't cover our costs because we had an underlying deficit. You'll remember from last year we had an underlying deficit of about 30 million, and that is reflected in this. We move on to the next slide. This is the COVID update. You'll see that we have spent 10.5 million on COVID, the vast majority of which is on hospital discharge programme. The actual increase in the costs around the packages of care are going to decrease because we've got new guidance in at the end of September where we are now carrying out assessments we weren't carrying out before. If you look at the next page, it outlines the risks. So our main risk that we are carrying is that the impact of COVID for the CCG is basically reducing our ability to live within our money for 2021. And then the recurrent impact of the additional services we're having to put in place and the reduction in provider efficiency is also going to cause increased costs in the system. We are looking at this to understand the additional costs and are discussing this with our providers. So we're working under the current framework till the end of September. So the main thing you understand about that is we are paying the NHS Trust on a block. We are receiving a post month end additional payment. We got yesterday the new guidance, which Claire mentioned, and we're working through that to understand what impact that will have on the CCG and probably what level of deficit that we are going to have to resolve by the year end, if possible. Do you have any questions?
Are there any questions? No?
No. Thank you.
Okay. So in which case we're asked to note the committee's activities, note the particular issues outlined in section 3, which Linda has discussed with us, consider the recommendations made by the committee and outlined in section 4, which is the agreement of the CCG procurement policy and the contract variation recommended in part, oh no, sorry, forget that bit. So it's just the agreement of the CCG procurement policy. So are we happy with those items?
Yeah.
Okay, thank you. That takes us then to the Quality and Safeguarding Committee report. And I believe that I'm starting with Pam for this one, please, Pam.
Yeah, thanks. There are two items which we wanted to bring to the governing body's attention, really. The first was about the Care Quality Commission publication about the Adult Attention Deficit Hyperactivity Disorder pathway. And we were really worried about this. We're really worried about these services. And we were seeking further assurance from the governing body members in terms of how work's ongoing. Now, I know that there's been an urgent decision with regard to this, so I'm wondering if that paper that went to the panel could be circulated to the governing body, and that might give some assurance to the members of the committee. And the second area that we wanted to bring to your attention was about non-accidental injuries to infants, because the Cheshire, Western Cheshire Safeguarding Children's Partnership has been directed by the national panel to undertake a serious case thematic review, which obviously the committee will receive and will report back on this at a later date. And finally, in terms of our recommendations from the committee, we're just asking the governing body to approve the serious incident policy as detailed in the appendix.
Thank you very much. So I think Tracy has something to add about the ADHD. So Tracy, do you want to add that?
Yes, so there's a number of things to note with ADHD. So a business case was approved in January by execs, and then, as you've heard, the governing body reapproved the funding to invest in ADHD services. There's a number of assurance letters that I've provided to NHS England, and have made sure that they have that awareness. So I'm happy to share those with governing body members so that adds to that assurance. And I just think that might be quite useful to make sure that is covered off. I'd also like to make sure that we're clear on which risk log that sits on. I don't think we need to answer that now, but that will be something that we'd just make sure that we've got everything lined up in terms of risk and governing body assurance. So there's a lot of information already out there, and the decisions have been made several times already. It's about the implementation of a service that's really important around the clinical risk factors. So happy to provide those if that gives the answer to the question, Pam.
I think that would help. Yeah. I think that would help, Tracy. Yes.
Well, thank you. So any further questions of assurance on that section? No. If not, I will just.
Andrew, sorry,
Yeah.
I've been trying to send a thing in the chat, but it seems to have disappeared. Yeah. The ADHD is becoming a local bone of contention. I don't know what it's like in other areas. I've had quite a lot of comments from GPs about the services, accessing them, what the pathway actually is, what is being asked of primary care, which are new asks, which were deemed unreasonable pre-COVID, and now the GPs are quite really quite irate about what is sometimes being asked of them post-COVID. So I think it's really important, because it's an expensive service, and I think and isn't really currently covering what was required. Obviously, there's now been a sign-off recently, so I think we could really do with seeing, or somebody or one of the other committees could do with seeing what the pathway is, so we understand the ask. It's a real irritation.
So some people might wish to comment on that, but my understanding is that the ADHD services, there are challenges, and I think it goes wider than Cheshire. It might even go wider than Cheshire and Mersey. But you're quite right, Fiona. We should be perhaps ensuring that one of the committees is cited on that. Paula, you said you wanted to comment. Is that about that point, or come in anyway, Paula?
Yeah, thank you. I think this is a great opportunity to reflect on how the committees interact actually and interrelate. So Tracy's made a point about being clear about where the risk sits, and in terms of the way we're managing our new risk register framework, it does clearly sit with another committee outside of the Quality and Safeguarding Committee. But actually, I think the role of the Quality and Safeguarding Committee, when we see other intelligence that's lined up, for example, maybe with complaints or queries from primary care, or when we have people ringing, for example, on the PALS helpline, that would then be reported to the Quality and Safeguarding Committee, and that's where the opportunity to triangulate is. So I think this is I think for me a real positive, that actually the majority of it's dealt with as a risk that's held through another committee under Tracy's leadership, but in actual fact, when the Quality and Safeguarding Committee see other intelligence from other sources and want to seek some additional assurance, I think this is a great opportunity where actually committees can share some information and dialogue at governing body level. And I think this is a great example of that, really. And it's not to take away from the risk. It is in terms of the primacy of another committee. It really is just to ask perhaps through a different lens on things when information comes from a different way. So recognise that could take us into a whole different governance conversation about where risks are managed. But my experience of good governance doesn't mean allow for other committees to perhaps come in and ask for some additional assurance based on some issues and concerns that arise in another way. And that isn't to say we don't feed that through. at a different level, and we don't wait for it to bubble up to governing body level. But certainly I think it's a good example of how we can connect committees together, make use of the primacy of the risk register which we've got and Tracy's leadership. So I think this is a good example to highlight how we've had previous questions from governing body members about how the risk registers and things fit together. And I think this is a great example of where we have the confidence to do that interconnectivity in a public meeting.
Thank you very much. Are there any further comments on the quality and safeguarding report? No? In which case we're asked to note the committee's activities, consider the recommendations made by the committee as outlined in section 4, with the committee approving the CCG serious incident policy and recommendation that the governing body endorse the policy for publication. It might be interesting to note that we've now changed things so that actually committees will be able to approve those sorts of things on their own governance from going forward, but at the moment we were required to do that. So looking around, is there anybody is discontent with us adopting those? Seems not. So thank you very much. That will take us onto the primary care committee. And just a reminder that within the primary care committee, the one thing that Fiona has asked me to point out is that within the primary care committee there is a consideration regarding the closure of a branch surgery, which is her surgery. So if this were decision making, you would be conflicted, Fiona. I think it is right that we're open and front and transparent about that, but of course the primary care committee is a committee in its own right and makes decisions about that independent of the governing body. So we have no role today in making that decision, and so I don't think that we need to do any special thing to account for that potential conflict. But thank you for being open about it. So primary care committee commissioner report, and again it's yourself, please, Pam.
Thank you. The same conflict of interest applies actually for the enhanced care and in-home service, because GPs receive some money for that too. I'm not going to go through the decisions that were made because they're set out in the paper, but I can just assure the governing body that there was very robust debate and discussion about those decisions, some of which were really quite difficult given our financial situation, specifically the one about enhanced care and care homes. We spent a lot of time on that, and it was a difficult decision that the Primary Care Commissioning Committee had to make. But if anybody's got any questions, then I'm happy to take those.
Are there any questions? Okay, I've got nothing in the chat box, so thank you again. So we're asked to note the activities of the committee and note the particular decisions that the committee took outlined in section 3.
Sorry, Andrew.
Yeah.
Sorry, I think I know this committee is a decision-making committee, but I guess it's, the committee agreed an option for funding for enhanced care homes. Do we not want to know what either the option was or the decision? I don't know. I know this. It's not for the governing body to say yes or no, because the primary care committee is a decision-making committee. But I'm afraid if I read that, unless I knew what the option, I wouldn't know what that is saying. Agreed an option for funding, doesn't know what option, what funding. Don't we need a bit more detail? That's what I'm saying, because it's. I mean, these are, and I guess we've all got to get used to this new way of receiving committee minutes, notes. But I mean, I guess it's the balance between brevity and assurance, isn't it? I think this has gone to the extreme that I don't know what that means.
Okay, so
I agree with you, Claire, in terms of the Primary Care Commissioning Committee. I think we probably need to look at the template again, because I think you do need to know exactly what we decided. I mean, the minutes will give you that, but in fact, the minutes haven't been approved yet. So, but I think we need to look at that. I do think we need to look at the format. I agree with you.
Yeah, because I mean, in the AA report, the ask was to put more detail into, the decisions that the exec team's made under its own, accountabilities, and we give quite a lot of information now, and this, there's absolutely no information. So I think we need to be consistent, don't we, in terms of the committees, the level of detail, please. Thank you.
So, I don't want to start a debate now about what needs to be in the report. So we will do, I was planning to do a review of the meeting at the end of the meeting, and that certainly it was something I expected would be discussed, as this is a new way of working. There is difference of opinion across different members about how much should be in, but personally, I think there does need to be enough in that we are informed of what decisions have been made, so that all governing body members are aware of what's happening in the committees. There is a degree of we're assuring ourselves on that the assurance has happened, aren't we, at these committees, rather than redoing what the committee has done in terms of that scrutiny. But I agree, Claire, I would like to see sufficient detail that governing body members are informed of what the committees have done, so they know what's happened, they can talk outside about what's happened, that they're not talking to sort of stakeholders not knowing what some of our own committees may have decided. So I do think there needs to be a degree of
thank you.
Right, that's where we got to. Primary care we've done. We have a governance and audit committee, which we're starting with Peter, please.
Thank you, Dr. Wilson. There are no issues that I'd want to draw the attention of the governing body to. So unless there are any questions, I'll just move on from this particular item.
Thank you very much. Are there any questions? No. We're asked to note the committee's activities and note the particular issues outlined at the section, it says, but I don't think there are anything, so we don't need to do that. We just need to note the committee's activities. Thank you. That brings us then back to Pam, Remuneration Committee, which is on page 188 of your report. So Pam, please.
Okay, there are two main items here. The first is about draft paper protection policy, but the second, the GPs on the governing body are actually conflicted. You're not, Andrew, but the 4 GPs are.
And I think we agreed that they would mute themselves during this this item.
Yeah, that's fine. The first item is about the draft pay protection policy, and we debated the policy that was put before us, and we've actually asked for further work to be carried out in respect of this, looking at comparisons with other CCGs outside of the local area. So we will bring that back to the governing body when that's been done. The second item is about at the last meeting of the governing body, we approved the CCG's remuneration framework, but I know that Dr. Mike Clark raised an issue at the governing body, which Matthew Cunningham agreed to go away and look at. And as a result of that, he brought a paper back to the remuneration committee. And what happened is the GPs are all paid the same sessional rate. And the GPs that I'm talking about are the governing body members, the clinical leads and the associate clinical directors. But for some reason, the governing body GPs are treated differently with regard to national insurance and pension contributions. So the remuneration committee were given a number of options how we could actually deal with this, because we felt quite clearly that they should all be treated, everybody should be treated the same. And so the recommendation, which is on page 190, is what that's come out of the committee. And that is that, and I have to be very careful how I read this. The committee agrees to recommend to the governing body that a sessional rate of 320 exclusive of employer national insurance contributions and exclusive of employer pension contributions be paid to the governing body GPs. And we also therefore need to change the remuneration framework if we agree to do that. So I'm asking the governing body to agree that in terms of the remuneration of the governing body GPs.
So looking around, with the exception of the governing body GPs, of course, who we will not look at all. Claire.
Yeah. I come in, Andrew?
Yes, please do. Yeah.
Okay. Absolutely support this, but I just want to confirm, my understanding is they've already been paid this way. It's just that the contracts aren't consistent with the way they're being paid. So I want to sort of, I suppose it's about the reassurance that the GPs have all been paid the same way. It is just that the wording in the REMCOM previously and the contracts were incorrect. So no one has been disadvantaged financially. This is just for absolute completeness and tidying up the detail, I think, my understanding.
Yes, that's right. That's right.
Thank you.
Thank you. Sorry, carry on, Pam. I think there is a agreement on that point.
No, that's it. That's all I need to say.
Okay, lovely.
I
Thank
just
you very
need
much.
you to agree that they're all treated the same and therefore change the remuneration framework to reflect that, because it's not right.
Okay. So I won't read it out, but on page 188, the governing body is asked to, and there are 2 bullet points and 2 sub-bullet points there, which is, largely Pam has just read out. So, and I think we have agreement on those points. So thank you for that, Pam.
Thank you.
And that moves us to the Strategic Commissioning Committee report. So I'm handing to Wendy for that, please.
Okay, thank you. The committee has a slightly different format, as you'll see from the other ones. We're still evolving what needs to go in and what could be reduced. So comments regarding the content of this report will be very welcome outside the meeting. You will see that a number of items that have been on today's agenda were actually debated at the Strategic Commissioning Committee. We actually debated a lot around the cancer, wait times and the issues, and I can assure you that a great deal of debate was around the performance issues, especially around the cancer areas, and also looking at the recovery plans. But now we've actually had the presentation. That's great today, so I won't go any more about that. Where the recommendation, you can read any of the rest and ask any questions of it later, but the recommendations for the committee around the Transforming Care monthly report, Tracy can come in if she wishes to on this one, but we thought that as this was now moving along extremely smoothly and a lot of the issues had been addressed, bringing a monthly report which was fairly short to every meeting of the Strategic Commissioning possibly was not necessary any longer, and that a quarterly report to update the committee would be sufficient. So today we're asking for the governing body to support that proposal. So I'll leave it there unless there's any other questions.
Are there any questions? Oh, Tracy.
It's not a question, but it's just to clarify. I think it's important because it does relate back to Mr. Cairns' question. So what we're proposing is a quarterly report to the Strategic Commission and Performance Committee, and then in the summary report that comes to governing body, that would be reflected on a quarterly basis on Transforming Care and all associated aspects of that, which I won't list. But I just want to be clear that everybody understands that that's what we're recommending, and that beneath it that sits, and I'd like that to be recorded, adequate governance on a monthly basis to review performance. And if we move to a place where we are less assured and the risk increases, then I think we would be proposing to increase the frequency again.
Thank you very much. Paula, have you got is that for this section? You've got a question?
Yeah, it was a point around cancers actually, Chair, and I think it speaks to the point about actually sometimes the committees that they overlap and they need to join up, and the point at which they do this is the governing body. So the escalations and the detail around cancers is obviously there for everybody to see, but the new layer of information that needs to kind of just be added onto that is about harm reviews. There's work going on locally, regionally and nationally about harm reviews, and that isn't just for cancer. So it's really just to bring together perhaps some discussions at Quality and Safeguarding Committee, and I recognise now that templates don't allow for all of the detail and some of the richness of that discussion, so I really felt it was important to draw that point out. There is a template in a process around cancer, but there is actually something that we're hearing that possibly may be landing in October for harm reviews in general in terms of non-cancer pathways.
Thank you very much. And I think that concludes that item, but it is a good reminder of Mr. Cairns' questions, which of course 2 of which we would have picked up during the strategy on engagement and involvement, and we've now not done that because we've deferred that item. So I just wonder whether we are in a position to answer those 2 questions in isolation, which are on page 162, who is going to be on the Cheshire Engagement Reference Group, and then a question regarding why are people and communities right at the bottom, as if we don't matter, on page 165. Are we in a position to do that in isolation of the paper? And if so, who would be able to help with those? Maybe we're not.
I would suggest it, Matthew, and the comms team might.
I was going to say it relates to the strategy, doesn't it, that we're going to talk about. We're going to defer to the next meeting, so I think probably in the presentation of that at the next meeting we can answer those questions, as long as we get back to Mr. Cairns and say that. I think that would be reasonable.
Okay, I was just conscious that we made a promise to answer the questions at the start of the meeting, and then by deferring that matter would be reneging on that promise. So perhaps if we can answer those questions directly to Mr. Cairns then after, rather than wait potentially 2 months for those questions, if that was possible, perhaps you could do that. Okay, so then I've got to find my place again now. That takes us to the corporate governance programme update, which is for you, Matthew, please.
Hi, thank you, Dr. Wilson. So again, recognising time, this is just a bit of a brief update on a number of key corporate governance documents which are hyperlinked within the paper, and which are not necessarily for a governing body to go through today, because we're really asking the governing body to note that the Governance and Audit Committee will be considering these at their meeting next week. The key ask really is regards to the governance review that we've talked about a number of times now, with regards reviewing our committee effectiveness and what we need to do going forward, which we've touched upon a little bit today. So on the basis that I believe everyone's read the paper, I'm more than happy to answer any questions around it, but the ask is still there really to note and give the authority to the Governance and Audit Committee to oversee the governance review that we're going to be doing in the next month. There you go, Andrew. I don't know whether you're frozen then. Sorry.
Frozen in real life rather than virtually. Thank you very much. Are there any comments regarding the governance section?
Andrew, sorry.
Yeah, go on, Claire.
No, I'll just say I think it's the right thing to do is for GARC to oversee this, but I think it would be helpful as soon as possible to understand what the requirements of that session are. And I know I've spoken to Matthew about this before in terms of the pre-work, the format of the day, the format of the session, and then the next steps. I think governing body need to know that as soon as possible. I'm sure that will come through GARC, won't it? But I do think it isn't long off now, considering it's the 17th. So we need to get on with that, please.
Yeah, absolutely. Thank you very much. I think there have been a number of items today, a number of occurrences where the interaction between committees has been important, and so I think the review will be very welcome, won't it? And I think productive. So thank you. Any last comments on that item?
Yeah, Andrew. Sorry.
Oh, sorry, Pete.
Yeah. I'd like to know what the governing body's expectations are in terms of the Governance and Audit Committee reporting back on this. Because I've got my own views as to the extent of the task, and I've still yet to see a work programme other than the date for the workshop which has been set. For the purposes of the governing body's forward planning, and also for managing your expectations, I need a steer as to how long you think this should take for when we receive the terms of reference next week at the Governance and Audit risk committee.
So Matthew, you may have some advice for us as to what we should be thinking.
No, that's fine. So me and Peter did have a chat earlier on the week around the thoughts around the workshop and what we were looking to get in terms of products, and then we were going to go through that in a bit more detail at next week's Governance and Audit Committee. In terms of timeframes, again, some of that will come out of the workshop depending on the substantiality of any changes that might come out of it. We've got the ability to make some quick changes, but there are others that will take longer, depending on if there's any radical changes that need to be done and impacts on the Constitution. So I would imagine, in terms of reporting back from the Governance and Audit Committee, we'd be able to articulate what's come out, hopefully, of the initial workshop, depending on the timing. And if we were due to have the governing body meeting in November, you would have that update anyway. I would anticipate that we wouldn't really want to make any major radical changes within this financial year, considering where we're coming up to during Christmas and the winter period. That said, I can't preempt what comes out of the workshop in a few weeks' time. But to go back to Claire's earlier point, again, more detail around our planning for the workshop, we'll make that available to you next week. And there will be some pre-work.
So two considerations there. Is that sufficient guidance, Peter, and did the governing body agree with the words Matthew? We've asked Matthew to put in that.
It's it's a decision for the governing body, isn't it, as to how the committees are structured and how quickly they want things to move. I can't really give a commitment to be able to come back to the governing body in November with a blueprint, not having seen a work plan. Now, as I said, it's if the governing body is content for me to merely update on progress in November and not give me an end date, that's fine. I'll work with that, and I can even come back with my view as to what an end date should be, or the committee's view as to what an end date should be at that time. Because as Matthew said, it may not be appropriate or practical to try and make any changes to committee dates and committee structures this side of Christmas, let alone in this financial year, let alone this side of Christmas. So it's really what people's expectations are. I'm not ruling out us identifying as a body some quick wins we can put in place straight away, but fundamental changes, if that's what's required, are going to take a little bit longer.
That sounds like a sensible framework to me. Peter?
Yeah.
Is anybody in agreement with that? It's a degree of flexibility. So I think it's essentially at least an update for November, please, but depending upon need and possibilities, it may be a bit more than that, but at the minimum, an update. Yeah, we're happy with that? Lovely, thank you.
Thank you.
So from the corporate governance programme, I haven't looked at my little box to see if anyone else has typed in the box. I haven't, good. Then we are asked to note the development and production of the key corporate governance documents and agree the Governance, Audit and Risk Committee to have oversight of the committee governance review and report back to the governing body. So thank you very much. That takes us then to section 6.1, which is the forward planner, which you can see before you and which is for information. Are there any comments? Okay, which takes us to the next section, which is everything's just disappeared off my screen, which is very disconcerting. Is any other business? So are there any other items of any other business? No, in which case that takes us only to the end of the public part of this meeting. We do have some more business to conduct in private. So as you will be aware, even though this is a virtual meeting, in order to stop the recording and stop live streaming to the public, the governing body needs to pass a resolution to exclude the public due to the confidential nature of the business to be discussed in accordance with the National Health Service open brackets, Clinical Commissioning Group, close brackets, Regulations 2012, section 16(1). Are we content to pass that resolution, one that you know well, because I've read it out many times before, in which case, thank you very much. Thank you for your input into the meeting, and my apologies that it has run over quite significantly, and thank you for those members of the public who have stayed with us. Thank you. And a reminder that